the planning committee, Dr. Tamara Shankier and Dr. Grant Ailing, who worked with us on arranging the agenda. I'd like to thank both of them for their contributions, and especially thank Manita Sundar and Jenna Bentley from our supportive care program, who have worked endlessly, really many hours, to try to get this program together. Just to remind you, the handouts on the right side of your screen, if you click on handouts, at the very bottom is the conference agenda and the slides. People are asking about the slides. If you click on that, you can download the handout with all of our presenter slides. Also, please go to the Q&A and write out your questions so that we can have some questions for the Q&A to address. Our next speaker is Dr. Lynn Stratman. Dr. Stratman is a cardiologist at Vancouver General Hospital, and she has an expertise in supportive care and education of family practitioners, developing practice guidelines, and she's medical director of the heart failure program at VGH. Her talk this morning is cardiotoxicity related to cancer therapies. We'll switch over to Dr. Stratman.
Good morning, and thank you for the introduction. I'll just go back here. So today we're going to talk about cardio-oncology and the intersection between cancer and the heart. These are my disclosures relevant to the clinical trials that I'm currently ongoing. What I'd like to talk today is what's the role of cardio-oncology, particularly with an emphasis on survivorship, and discuss some of the cardiac complications of prostate and breast cancer therapies and where those fit in the survivorship roles. I also want to explain a little bit about the rationale for risk factor modification, both during and after treatment. So what is cardio-oncology? Cardio-oncology is a relatively new discipline. It recognizes that people with cancer have unique cardiovascular needs. Many patients may need cardiovascular assessment and treatment either before, after, or during cancer therapy. But cardio-oncology started in the breast cancer world with the fact that Herceptin caused heart failure. We now know that many drugs have cardiotoxic effects, and we have to bring in a lot more different modalities, including our EP colleagues, cardiovascular imaging, and our rehab colleagues. So why cardio-oncology? Well, consider, as Dr. Moyet has talked about, there are significant overlap between the risk factors for many cancers, such as breast cancer, prostate cancer, and cardiovascular disease. Therefore, it's important to modify both these risk factors when we treat disease. We also know that sometimes the treatment of cancer can lead to worsening of cardiovascular disease. Why is cardio-oncology important? Well, when we look especially at our survivorship data, this comes from the USA, we can see that the number of survivors of all cancers is significantly increasing in the population. We also know that when we look at the general population, patients tend to be messier than the clinical trials. They're older, they have more comorbidities, and they've had more previous treatments. Because these patients are surviving, we need to think about how we will follow them for the long-term effects, especially on their heart, of their chemotherapies. We also know that cardiotoxicity can occur in many more treatments now than just anthracyclines. Every day there seems to be a new drug on the market which can lead to cardiovascular toxicity. Most recently, that has been the checkpoint inhibitors. Commonly, we are seeing at least one patient a month now having to come in because they have developed a myocarditis secondary to their checkpoint inhibitor. As these new therapies are being developed, we're seeing more and more cardiotoxicity. So now let's talk about specifics. What about breast cancer? This data comes from the SIR database and looked at almost 64,000 patients who had breast cancer. Not surprising, cardiovascular death, which is the leading cause of death now, we have beat cancer, occurred most likely in those in the early age group who died more likely of a cardiovascular cause than in the group that died from the cancer itself. Why are women dying from cardiovascular disease more than their cancer? Some of it could be due to their underlying risk factors, but some may also be due to their treatment. If we look particularly at the second slide here, we see that cardiomyopathy or heart muscle weakness is a long-term risk of especially anthracyclines. We know that the risk of cardiomyopathy increases every year post-chemotherapy. We used to think that if we monitored for 5 years and there was no significant increase in cardiomyopathy, then we were okay. However, we know from the pediatric literature, which now has followed some pediatric survivors of cancer into their 40s and 50s, that the risk of cardiomyopathy continues even 30 to 40 years post-treatment. We know that drugs such as anthracycline can cause cardiovascular risk factors, but what about other treatments? Radiation is commonly used in breast cancer. And if we look at this slide here, we see that radiation has many effects on the heart, most of which do not happen in the first few years post-treatment. An uncommon side effect is that of pericardial disease, which causes constriction around the heart and does not allow it to both squeeze and relax properly. In the late 2010 to 2013 period, there were several articles which showed a significant increase in the risk of coronary artery disease in women who had received particularly left-sided radiation. The risk usually came around 10 to 15 years post-treatment. There recently have been some other clinical trials that have suggested with newer methods of radiation that this risk may be slightly less in those who are radiated after 2010. Radiation can also lead to diastolic dysfunction, where we see a sort of hardening of the heart. Women in particular are sensitive to diastolic dysfunction. They often develop diastolic dysfunction more often than their male components when they have hypertension. And lastly, radiation can lead to cardiac valve disease. So what happens if you do get chemo and radiation damage to the heart? Is it possible to improve cardiomyopathy using common heart failure drugs? What we know is that from this study from Cardinal in 2012, that usual drugs, ACE and beta blocker, which have been promoted heavily in heart failure management, can afford the same improvement in cardiomyopathy for people who have had anthracyclines. All of this data has recently led to the European Society of Medical Oncologists putting out guidelines in 2020. These are particularly important to those with breast cancer. What it actually suggests is that in asymptomatic patients who are treated with any cardiotoxic agents and have normal function should receive screening approximately 6 to 12 months and at 2 years post-treatment, and thereafter periodically. They have not yet defined what periodically means. Some people suggested this should be at 5 years or whenever patients develop symptoms. It did, however, state that those who developed LV dysfunction or heart failure due to any anti-cancer therapy and are receiving medications should remain on their anti-heart failure medications lifelong and should continue to receive regular cardiac review, for example, annual if asymptomatic. These recommendations were 3B by the committee. They also suggested a few other recommendations which did not get a 3B recommendation. They suggested that those that had a history of mediastinal chest radiation have an evaluation for coronary artery disease and valve disease, even if asymptomatic, at 5 years post-treatment, and then every 3 to 5 years thereafter. Like Dr. Moyed said, it was recommended that all patients be encouraged to have regular exercise and healthy diet. The interesting topic comes about, what about those patients who only received hormone therapy and never received chemo or radiation? Sometimes we do not think that these patients are at increased cardiovascular risk. This study, just released in 2020, compared patients who received hormone therapy and other types of chemo and radiation. They showed that patients who just received hormone therapy, which is the highest rate of curve for cardiovascular non-fatal events, was in the hormone group. Interestingly, this group also was an older group and may have been a group that was excluded from receiving other chemotherapies due to their age and comorbidities. But they still had a significant amount of non-fatal myocardial adverse events. They also had a significant increase in fatal myocardial events, as did some of the other groups. One of the interesting topics is always, can we predict who will develop cardiac events after chemotherapy? This paper by the group in Toronto was recently published, and what they did is they looked at an administrative database of all women in Ontario diagnosed with early breast cancer between 2003 and 2014 and followed them through 2015 and developed a score for MACE incidences with candidate predictors. This is the score categories here. You received points for your age and points for your past medical history. For example, if we thought of a 65-year-old woman who may have atrial fibrillation and heart hypertension, she would get a total of 30 points. When we then plot her on the scale with her risk factor of 30, her 5-year risk of having a major cardiac adverse event is almost 10%, and her 10-year risk is almost 19%. She is therefore someone who should really receive very aggressive risk factor modification. So what about prostate cancer? Well, one of the things that we know is that prostate cancer and cardiovascular disease share a number of risks. If we consider that in any group, if the risk of cardiovascular disease is above 2%, then that is considered to be high global risk. When we look at prostate patients, we know that their risk of myocardial infarction, stroke, or cardiovascular death at the time of diagnosis is greater than 2% per year. That risk is increased to 4% per year in those that have received ADT therapy. Why is that? Well, if we look at this graph here, we see that there is definitely a link between cardiometabolic syndrome, so that refers to all those risk factors such as obesity, high cholesterol, diabetes, hypertension, leads to cardiovascular disease. There is some thought that those same risk factors may be responsible for prostate cancer. We know ADT therapy, which is the cornerstone of treatment of prostate cancer, can increase the risk of cardiometabolic syndrome, therefore increasing the risk of cardiovascular disease. And there is somewhat a link between actual androgen deprivation therapy generally affecting cardiovascular disease. Therapies for prostate cancer act at many ways to decrease testosterone. What happens with the decrease in testosterone is that we have indirect and direct effects on the cardiovascular system. Testosterone decrease leads to a decrease in lean body mass and an increase in fat mass, which causes an increase in insulin resistance and hyperinsulinemia and diabetes. We increase cholesterols, and we get an increased thickness of arterial walls, which aid in sort of making the hypertension. We also know that T cell activation can cause destabilization of fibrous plaques in the coronary arteries and actually can lead to a decrease in contractility. Vasodilation is very important, especially if you have coronary spasm, and low testosterone decreases vasodilation. So is there any difference between the GnRH antagonists and the agonists? We know that they both act at different points to lower testosterone, and there has been some debate as to whether one is better than the other. When we look at data, there is no randomized control trial currently available. Albertson took 6 clinical trials, put them together for a total of 2,300 patients. What he demonstrated was that there was a lower risk of cardiovascular events or death in all patients when treated with daguerreolex instead of other GnRH agonists. He showed that this was more prominent in those patients who already had underlying coronary disease. This has led recently to the PRONOUNCE trial, which is randomizing patients 1-to-1. Currently, there are around 600 patients in the PRONOUNCE trial, the results of which will come out later. What about other cancer treatments and their effect on the cardiovascular system? We know that in trials that have included drugs such as abiraterone and enzalutamide, there is an increased risk of major cardiac events. We also know that certain drugs can have serious interactions with commonly used cardiovascular medications, and this is important to think about before starting those drugs. Many men with prostate cancer also have hypertension and possibly atrial fibrillation. A lot of the commonly used meds, particularly for atrial fibrillation, can have significant interactions with drugs such as abiraterone and cause bradycardia and increased bleeding. I think this leads to the question of, we know prostate cancer patients have higher baseline cardiovascular risks and characteristics. The question should not really therefore be about whether we need to look at which drug, but how to prevent this in the general population. So the American Society of Clinical Oncology has come out with some recommendations in addition to the American College of Cardiology, and this has hopefully made a simple algorithm so that all patients, particularly primary practitioners and those who may not be aware of it, whenever they're faced with a patient with prostate cancer or truly faced with a patient with coronary artery disease, to decide on how to do better risk factor prevention. So the first day is for awareness. And I think for my cardiology practitioners, I would say awareness that your patient with cardiovascular disease probably should have their prostates checked. We also talk about the use of aspirin because some drugs are prothrombotic. Blood pressure control. This is the goal in the normal healthy population. The SPRINT trial actually suggested the goal should be lower at 120/80. We talk about using both diet and drugs to lower the cholesterol, but being mindful that some prostate drugs may interact with statins in particular. All patients should be talked about cigarettes and stopping smoking, diet, and of course, exercise. And the recommendation is 150 minutes of moderate intensity exercise per week. The other thing that probably all patients should have is an ECG, particularly if they are going to start on any drug that could prolong their QT, and make sure their other drugs they're not in atrial fibrillation at the time. So the last point I'll just talk about, we have what's called a cardio-oncology clinic at VGH, which is provincial. It started in 2012, and we had about 1,300 referrals to 2017. Between 2017 and 2020, we've had another 2,300 referrals. We're getting about 90 to 100 new referrals a month. And last month, we did 275 visits, most of them being virtual visits, Zoom, telehealth, and in person. And this is how you can get a hold of us if you need to. And I think, in BC and in Canada, we take collaboration to heart. Thank you very much.
Thank you, Dr. Stratman. Before I introduce the next speaker, just to inform the attendees that presentations are being recorded, and you'll be sent a link once the video is available, so you can always go back and relearn some of the key points. And also, you're going to be sent an evaluation form after the conference, and we'd appreciate you completing the forms so that you will be getting a CPD certificate for your participation as well. So, okay, our next speaker, I'm excited to have Richard Bebb back from his sojourns in the Middle East, and he's now on Vancouver Island. Richard's a good friend and a terrific physician, endocrinologist, after spent over 20 years in Vancouver before, as I mentioned, going to Abu Dhabi and now back to Vancouver Island. Richard was also a consultant to our men's health initiative at Vancouver General Hospital, where he demonstrated his fantastic teaching abilities. So I'm looking forward to your talk here, Richard, on cancer treatment-induced bone density decrease, treatment options, and thank you for being here this morning.
Thanks, Larry. I missed part of the introduction because I got cut off, but thank you for the invitation to speak and to the organizing committee as well. We're a little running behind. I try to keep on time here. So Larry asked me to talk about bone health in this population of patients who've been treated for prostate and for breast cancer. And I will go through a little bit. I've mixed slides a bit looking at both diseases, but I have to do one thing first because Dr. Moyad threw down the gauntlet. So I don't have any pictures of pets, but I do have our little guy, Sparky. I'm actually broadcasting from home today. So he's a pretty cute little guy. And there's my gratuitous moment with an animal, a nice little cute dog. So I'll start with the slides and I'll give some take-home points. First, osteoporosis and osteoporotic fractures are very common in both cancer patients and prostate cancer patients. Second point, there's a lot of commonalities in the pathophysiology of what's going on, and it hones in on estrogen deficiency. Third point is we have effective therapy to reduce the morbidity from cancer treatment-induced bone loss and maybe mortality. And I'll leave that to my oncology colleagues. And the fourth one is we're under-treating these patients despite having therapy that's available today. I don't have a disclosure sign, but I have no connection directly with any of the products I'm going to talk about. And I do mention the two main agents that we have to treat. So what are the potential benefits of treating this patient population? The first thing is reduction of osteoporotic fractures, of course. The second is reduction of skeletal-related events, or SREs, and that includes pathological fractures from metastases, need for radiotherapy or surgery to treat those metastases, spinal cord compression, and in some patients, hypercalcemia related to the bone involvement. Third issue is improved quality of life, and the fourth one is possibly improved survival with this group of patients. So let's look at this in a bit more detail. When patients have bone complications, it adds to medical costs, definitely. I'll show you some data on quality of life. It has an effect on mortality in prostate cancer in particular. I mean, we know in general men do less well in the general population, if they have a hip fracture compared to women, it's worse in this population because this population, they're survivally even more affected if they get a fracture. And the data on quality of life is quite significant, looking at mobility. And 25% may be placed in a nursing home. And of those that aren't, 50% have a significant disability. It's about 25% that resume a similar pre-injury quality of life. So there's a lot of downsides in addition to the malignancy. So what's going on right now? How are we doing as a report card? I've got 3 studies here I've referenced looking at what's going on with bone health in prostate cancer patients. The first study looked at hormone-naive prostate cancer patients at the time of diagnosis, and 38% of them already have osteoporosis, even before any therapy. If you look at perhaps more involved, more aggressive disease, castrate-resistant prostate cancer, and use the FRAX analysis, that number goes up closer to 50%. And then the third study, the ERS-223 study, and this is an oncology study looking for therapy for prostate cancer. They looked at these men who, again, had very advanced disease compared to the average patient who's got disease, confined to the prostate. And in this group, only 40% of them had received an anti-resorptive agent at the time of the study entry. So we're under-treating them. And then if 2 of the key take-home points of this whole talk is even in this very high-risk group that have an inherent risk of getting osseous metastases, most of their fractures are osteoporotic fractures and non-pathological. And most of those are occurring in the first 12 months of therapy. So it's something we should be focused on to intervene earlier. This is another graph looking at this longitudinally in prostate cancer patients. And again, at the time of diagnosis, somewhere around 35, maybe 40% of men qualify as having osteoporosis. And then if they're put on androgen deprivation therapy, that number progressively goes up. And by 10 years, it's over 80% of them are going to have osteoporosis. And that's not just a number. That translates to a risk of fracture. So what's going on? The mechanisms of bone density decrease in cancer therapy has similarities if you compare breast cancer to prostate cancer. Both are exposed to potentially bone noxious agents and cytotoxic therapy that doesn't get along with the bones. There may be radiation, surgery, decreased mobility. Both of those cancers are treated through hormonal therapy, be that aromatase inhibitors in breast cancer, anti-androgens in prostate cancer, and both are exposed to GnRH agonists, further suppressing endogenous sex steroids. And now with prostate cancer, the GnRH antagonists seem to be used more commonly. The common denominator here is that both will have a reduction in estrogen either directly with breast cancer, or if you reduce androgens in men, you're effectively reducing estrogen as well. The net effect is a reduction in bone mineral density. This cartoon explains what's going on inside the bone. So here are the osteoclasts. I don't have a pointer here, but at the top of the graphic is the spotty cells, if you will, the 2 of them there. Those are the osteoclasts chewing away on the bone. The blue cells are the osteoblasts. And in orange is the rank ligand. A rank ligand stimulates osteoclasts. It's not a good thing to have high levels of in your bone. And it's suppressed by estradiol. So if you reduce estradiol, rank ligand goes up and osteoclast activity increases. OPG on the left side of the cartoon is osteoprogerin, which is the other main mediator, and it serves to counter that effect. So if you reduce estradiol in the bone, you end up with increased osteoclast activity, and it sets the stage for bone loss. So let's talk about estradiol. This graph is an old one from Kozla. It shows different states of existence for men and women. On the right side of the graphic, you've got pre-menopause women, of course, have the highest estradiol levels. Next bar graph over is young men, and as you move from right to left and men are aging, testosterone levels trend down, and so estradiol levels trend down, and that correlates very strongly with bone health and osteoporosis risk. Postmenopausal women on the far side on the left have the lowest levels, of course. The humorous thing I often point out to men is if your wife is postmenopausal and not on hormone replacement therapy, you have a higher estradiol level than she is, and that's actually a good thing. Good from the perspective of your bones. Now, looking at this again, here it is, estradiol levels. This on the far left is the bioavailable estradiol. Premenopausal women dropping to postmenopausal women, and then in the blue, normal men. And if they're under androgen deprivation, you can see how profoundly low the average man would be with estradiol levels. What does this do to bone density? This is a graphic showing different patient populations and how much bone loss will occur in 12 months, very quickly, 1 year. So it's accepted that after the age of 35, most of us are losing maybe 0.5% of bone density per year of life as a natural aging phenomenon. It accelerates in the early postmenopausal state in women up to around 2%, then slows down to around 1% a few years out. The bottom 5 bars are cancer related. And as you increase the intensity of suppression of sex steroids, you can see it gets worse. At the bottom, you've got androgen reductase inhibition and gonadotropin releasing hormone agonist therapy at 7%, and then ovarian failure secondary to chemotherapy at almost 8%. So that's in 1 calendar year. And to put it in context, if you look at therapeutic studies of bone agents, bisphosphonates, or whatever, you're usually looking at something at 2 to 3 years of about a 7% increase in bone density, which generally translates to a significant reduction in fracture risk. And that's over 2 or 3 years. This is happening in 12 months. It's very dramatic. So in this graphic here, the point of it is again a dose response phenomenon. This is men with prostate cancer. In blue at the top of the graphic, a straight line is those who were not given androgen deprivation. And then the other lines are increased intensity, escalating amounts of GnRH agonist. In red at the bottom of the graph is orchidectomy in the extreme. So you can see that the more you deprive men of testosterone, their fracture-free survival drops. So that's an effect. Now, there's 2 different classes of medications generally that we go for. I showed the earlier graphic with rank ligands. Denosumab, which is our antibody to rank ligand, is one of the agents, and by binding up rank ligand, it reduces the osteoclastic activity. Aminobot bisphosphonates work in a different way. They have a dual mechanism. They decrease the maturation into osteoclast, and they also have a direct effect, decreasing the ability of the osteoclast to resorb bone, thereby tipping the balance away from excessive bone resorption. So I'll run through a couple slides now, and I'm going to jump back a little bit from prostate to breast cancer, looking at what we can do to treat these patients who either have osteoporosis at the start or are undergoing androgen deprivation therapy. The first study here is with denosumab and looking at men with prostate cancer. On the left is lumbar spine and the right is total hip. And you can see a nice increase in bone density over 2 to 3 years, significant enough to have an effect. And on the bottom in the red is the placebo, which continues to lose bone in that cohort. Similar data in the total hip. Hip always responds slower than lumbar spine. What does that do to fracture rates? It reduces them either at 1, 2, or 3 years. And again, this can come on very quickly, quite a dramatic difference in the first year, 1.9% versus 0.3% new vertebral fractures. So treating early has an effect early. If we look at data in breast cancer, it was mentioned earlier, the Women's Health Initiative study, in women survivors of breast cancer. In that study, it was found they had a 31% increased risk of fractures. Very similar data in these women deprived of sex steroids, almost the same curve over 2 years using denosumab, increases bone density very nicely compared to an accelerated loss in the non-treated population. Again, translating to a clinically significant reduction in fractures. This is a study going out actually 6 years, which is really kind of nice because it's a long-term study, and it shows two things to take home. That, you know, how quickly at 6 months the curves are starting to disappear or to part. And you know, the mind's eye, I think the curves are still going apart at 6 years. So the benefit is early, long-lasting, and probably getting better the longer you keep patients on therapy. So the European Society of Medical Oncology has put out guidelines. This is the graphic from the original paper, and it was recently updated. And walk you through this publication from ASBNR that came out just this last year. And it has, before I go through it with you, it has the message that this is a high-risk population. And I'm going to try and put a little marker in here if I can get the color working on this. There we go. That's good. Okay, we'll try this. It has the message that you should treat this patient population more aggressively than a regular osteoporosis population. Okay, so you assess the patient. They've just been diagnosed. Evaluate them for osteoporosis. And I've just got this, you can see that little dot. Again, 40% of them may have osteoporosis at the start. You're going to treat that population. Next step, if they don't have osteoporosis at the start, decide what their T-score is. And if it's less than 2, they have a category to be treated. We know they're going to lose bone density. If it's better than a 1.5, you're probably okay to watch them. And then that in-between group between 1.5, minus 1.5 and minus 2, to do a FRAX analysis. And the FRAX analysis, as many of you know, is a World Health Organization maintained website. It's very, very useful. And if they're below 15%, or sorry, over 15% risk of osteoporotic fracture by the FRAX, they're candidates to be treated. Perfect. This is the FRAX. It's online. It's free. I use it every day. It's kind of fun. You can do it in front of the patients. You can fill it out. You can fiddle around with the data. You can look ahead 10 years and sort of see where they're going to go. And it's very helpful. Of those of you that use it, so you're probably used to the 3% threshold for therapy for hip fracture at 10 years and 20% for overall osteoporotic fragility fractures. And again, but in the androgen or estrogen deprivation groups, 15% is the threshold to consider osteoporosis therapy. So that's the gist of my osteoporosis part of my talk. And I would like to talk briefly about skeletal metastatic disease. Not too much. This is more in the oncology realm. Super common, 400,000 patients per year in the US. And with our patients who have breast and prostate cancer, 80% of the advanced patients are going to get some skeletal manifestation with metastatic disease. We have therapy that reduces these skeletal-related events significantly. And I'm going to run through just a little bit of this data. This is a cartoon graph that looks at different cancers. On the left is breast cancer, prostate's next over, multiple myeloma, and then other solid tumors. Couple of points. It looks like pathological fractures are more common with breast cancer. Prostate cancer seems to like the midline, the vertebral barriers, and so it has a higher incidence of spinal cord compression. Myeloma and other solid cancers seem to be somewhere between the two. There we go. Now, there's sort of three patient populations here. Those patients were focused on osteoporosis, those patients that have skeletal metastases, and there's been some work in high-risk patients who don't have skeletal metastases and may not yet have osteoporosis, but are at higher risk to develop fractures. And it's been tried to treat these patients. This is a study from SAD back in 2002 showing that you can reduce skeletal-related events, again, radiation requirement, pathological fractures, spinal cord compression, surgery, or other therapies required. You can do it. It has an effect, but there was a lot of side effect. You're using very high doses here. In fact, the zoledronic acid at 8 milligrams every 3 or 4 weeks was modified during the study due to renal dysfunction in too many patients. So I won't sort of talk much about this, but it has not been universally accepted in the prophylaxis. It's more in the situation of if you have a metastatic deposit. Now, which agent is the best? We have two classes of drugs. We've got denosumab, our antibody to rank ligand. We've got our potent intravenous aminobisphosphonate, zoledronic acid in two different forms, 4 and 5 milligrams. If you look at a head-to-head study here, which was published in 2011, denosumab was better in terms of reducing skeletal-related events head-to-head with zoledronic acid. The next two graphs are very busy, and I don't want you to look at the small print. I want you to just get a flavor of the comparison between these two agents. These are both prostate cancer patients. Hazard ratio reduction of SRE events, denosumab versus zoledronic acid, and you can see the trend to increased benefit with denosumab versus zoledronic acid. Subgrouped out, it's been busier, and I apologize for this, but you can see in breast, prostate, and other metastatic disease that although a lot of these abut the line of neutrality, the general trend is that denosumab seems to be a more effective agent, although, you know, it's a pretty close second for the aminobisphosphonate group. The other thing is not just fractures, quality of life. This is a study looking at denosumab versus zoledronic acid. And if you reduce fractures, quality of life goes up. But also there's an ease of administration. If you're giving a medication by subcutaneous injection in the clinic, takes a few minutes, off you go, on with your day, compared to zoledronic acid, which does require infusions and takes more time out of our patients' lives. Therapeutic side effects from the agents, denosumab and zoledronic acid. Both agents can cause osteoporosis of the jaw. In the osteoporosis population, where we're using lower doses, I have seen one case of osteoporosis of the jaw in 30 years of treating patients. So it is fortunately very uncommon. In the oncology realm, however, when you dose escalate, the incidence goes up and needs to be addressed. Hypocalcemia can occur in both of the agents. Clinical Pearl, always make sure your patients are vitamin D replete when you're treating them. And again, zoledronic acid, particularly in higher doses, can lead to some renal impairment. Gotcha. So this has come out in the guidelines. This is a breast guidelines from 2017 from ESMO. It states that a bone modifying agent should now be standard of care in patients with metastatic breast cancer. And same data exists from different groups for the prostate. I put this up because our own homegrown Karen Gelman was one of the lead authors of the paper. So what's available and what's approved in Canada? You have 4 options for breast cancer, 2 for prostate cancer. In reality, I think it's a decision between denosumab and zoledronic acid in most situations. The drugs aren't cheap. If you look at the cost of zoledronic acid in osteoporosis dosage, it's about $645 a year in British Columbia, and it takes some difficulty to get it covered. And if you compare that to denosumab, again, in osteoporosis doses of 60 milligrams sub-Q every 6 months, a little bit more, $716 per year. And again, there's a coverage issue. So I think we're up to my last slide, hopefully on time. Take-home points. Number 1, assess and start osteoporosis therapy early. Again, many patients have osteoporosis to start. If they're going to be exposed to androgen deprivation or estrogen deprivation, treat them before they lose their bones, the bone density. It's the first year is even important. Don't delay. People are often, I think, busy. They're focused on treating the cancer and the bones get forgotten. Second point is don't forget calcium and vitamin D. It is important. It's a nutritional component, as you heard earlier, very important. Number 3 is promote adherence. If you don't take the medication regularly, if you're late in your infusion or your injection, it's been shown the efficacy starts to drop off. They should be followed both biochemically and by intermittently doing DEXAs to ensure they're doing okay. And if your patient develops metastatic disease, you're going to often be using the same agents, but you're going to dose escalate up to the higher doses. And that generally is the time that they're going to get handed over to an oncologist to monitor renal function, calcium levels, oral health, etc. So I think that's my final slide. There's an old growth tree from the West Coast here, and I'll stop there.
Thank you. Thank you, Richard, very much. That was a great review. And there will be some questions. We're a little bit behind, but I think we're going to be able to catch up. And by the way, Dr. Moyad will come back on after our next speaker, just at the beginning of the Q&A, to give us his summary main points, which we lost because of the technical difficulties. Our next speaker, Dr. Melanie Altus, is a consultant gynecologist at the BC Cancer. She's a clinical assistant professor in the Department of OB-GYN at UBC. Recently joined the program at Vancouver General. She is dedicated to cancer survivorship, menopause, and vaginal health concerns. I'll ask Melanie to talk to us on sexual health in women with breast cancer, a practical approach. Melanie, thank you for joining us.
Perfect. Thank you, Dr. Goldenberg and the Planning Committee for inviting me. And today I'm going to speak about sexual health in women with breast cancer, which is a topic that I'm very passionate about. I have the objectives are listed in your handout, so I won't go through those in detail. I have no disclosures for this topic. We all know that sexuality is a very important indicator of quality of life, just in the general population. In a study that was done in 2010, looking at about 5,500 cancer survivors, it was actually ranked by cancer survivors as being the 3rd most common concern. So definitely a very important issue and topic to address. I'm going to talk today specifically about breast cancer. In my practice in the sexual medicine clinic at the BCCA, the two most common concerns I see for breast cancer survivors are vaginal dryness related to vulvovaginal atrophy, and this either causing a day-to-day discomfort or a discomfort just solely related to penetrative intercourse. I also see along with this frequently a decrease in sex drive. Other sexual health concerns that I see in breast cancer patients are a decrease in lubrication, as well as a decrease in the vaginal and genital sensations of arousal. Women with breast cancer can also have body image concerns related to the surgery plus or minus reconstruction, as well as limitations of movement due to the surgery and radiation. All of these things overall, you can imagine, would have quite a significant impact on the sexual self-image, sexual identity, as well as the sexual relationship. So what I'm going to start off with is coming up with a practical approach, and what I do in my office specifically related to vulvovaginal atrophy, which is also more recently caused genitourinary syndrome of menopause. So vulvovaginal atrophy, as we know, is due to a decline in estrogen. We sometimes will see that women who have breast cancer are may have more severe they may have more severe menopausal symptoms compared to women who go through menopause naturally. They may have premature menopause. They may have been on combined HRT up until the time of breast cancer diagnosis and then stop that and have resumption of their menopausal symptoms. Or for postmenopausal women who are on, who go on aromatase inhibitors. We know aromatase inhibitors will change or stop the production of estrogen in the body. So even women who have gone through menopause already will have a production of estrogen in the adipose tissue. So if they go on the aromatase inhibitor, it will decrease this quite significantly. So they may also have worsening of menopausal symptoms. So vulvovaginal atrophy is diagnosed by patient-reported symptoms as well as the examination. So patients will commonly report even a day-to-day dryness or discomfort in the genital area. They may report dyspareunia related to friction or rubbing, which then can cause prolonged irritation and burning. And even if the tissue is very thin and friable, it can lead to postcoital bleeding. Women may also report urinary symptoms such as frequency or dysuria or an increase in urinary infections. On examination of the vulva and vagina, you'll see a loss of elasticity, a decrease in the vaginal rugae. You may notice that there's decreased lubrication and a decreased epithelial thickness of the vaginal opening, the vestibule, as well as the vagina, which can lead to petechiae and friability. So what I'm going to do next is just show you a picture of the vulva. And I think this is, even if you think on history, a patient has vulvovaginal atrophy, I would highly recommend doing a pelvic exam. And this will confirm the diagnosis, rule out other conditions that can cause similar symptoms, such as dermatoses like lichen sclerosis. The other important thing is to do what I call an educational pelvic exam. So this is after you've done your assessment, giving the patient a mirror and for you to show them the anatomy, but particularly to show them the difference between the vulvar vestibule and the vagina, because you, in my approach, I give them treatments for the vestibule as well as the vagina. So you want to show them where to apply it. And I'll show you here on the, let me see, where is my, okay, I'll show you here. I can't see the drawing tool. Okay, so the in this picture here, the vulvar vestibule goes from the inner labia minora up until the hymenal remnant. So that's still part of the vulva, called the vestibule. The vagina in this picture doesn't actually start until you get beyond the level of the hymen. So if you're just treating the vagina, you may not treat the estrogen-dependent vestibule. If you don't have a mirror in your office, then I would recommend showing a picture on the internet. So getting on to treatment, all organizations that look after women's health, and particularly with menopause, will recommend for breast cancer survivors non-hormonal approaches as first-line choices. So I'm going to talk about that today, and in the next talk, Dr. Lipkovitz is going to go over the hormonal management. So I'm going to start with non-hormonal management in the moment. And so this is with lubricants. And I'm going to tell you more about lubricants than you've ever known. So for women who are experiencing vulvovaginal atrophy, I highly recommend a silicone lubricant during penetrative intercourse. The advantage of this is that it stays slippery throughout intercourse, whereas the water-based lubrications will frequently become sticky and need multiple applications during the intimate encounter. So silicone for vulvovaginal atrophy. Some patients will ask about oil lubricants. And in the research, there has been shown that mineral oil, petroleum, and olive oil can actually increase the risk of vaginal infections, so yeast as well as bacterial vaginosis. Right now, coconut oil is quite trendy, so I'll be asked about that a lot. The jury is basically still out on that, although I do have some women who will use an unrefined virgin coconut oil successfully. There is also a mix of silicone and water-based lubrications that combine kind of the advantages of both that some women do really like. However, the most common lubrications on the market and in pharmacies are the water-based lubrications. So it's important to know a lot about the water-based lubrications because not all lubricants are created equal. The advantage of the water-based lubrication is that it's non-staining, whereas the oil and silicone-based lubrications will stain clothes or sheets or wherever the intimate encounter is occurring. So some patients really don't like that. And they don't mind that it needs to be applied frequently during intercourse, particularly with the atrophy. The other thing to keep in mind with the water-based lubricants, they do require preservatives to prevent bacterial overgrowth. So some of these, particularly the propylene glycol and the glycerin, can be quite irritating. When you're considering recommending a water-based lubricant, it's very important to know about the pH and osmolality, and particularly because many of the lubrications that are on the market don't fit into the recommended ranges. So let's first talk about osmolality. The majority of lubricants on the water-based lubes on the market are hyperosmolar. So this means when they're applied in the vagina, they'll draw the water out of the cells. So you can imagine for someone who's already experiencing vaginal dryness, drawing water out of themselves is going to cause them to become more irritable, more shriveled, more symptomatic, and more irritated. The World Health Organization in 2012 actually published an advisory note about lubricants, and one of the things that they recommended was that lubrication should have an osmolality less than 380. Hardly any on the market fit into this range, so they recommended a maximum upper limit of 1200. And I'm going to show you on the next slide. These are common water-based lubes on the market. I've put a red box around the lubricants that are under the 1200 maximum. The white bars are the ones that are under the 380. So you can see that the majority are hyperosmolar and may cause more damage during penetrative intercourse. Particularly, I'll draw your attention to the KY jelly, which we as physicians use in our office a lot, as well as it's probably the most common lube that women will use. And before I go on to the moisturizers, I'm going to give you some of the brands that fit into these categories. Next, let's look at pH. So premenopausal vaginal pH is 3.8 to 4.5. When women go through menopause, the pH increases to greater than 5. And we know that this elevated pH can increase the risk of yeast infections as well as bacterial vaginosis. And as you can imagine, acidic pH would cause irritation to the tissue. So ideally with a water-based lubricant, we want it to fall in the range of that premenopausal vaginal pH. And I'm going to show you on the next slide a list of common over-the-counter lubricants. And again, you can see that the majority of them are quite basic. I've put a red box around the ones that fit into that expected range. But particularly if I can draw your attention to the bottom, where you see Replens, which we frequently use as a vaginal moisturizer, actually falls into that acidic category. So these are things just to be aware of. If patients come to see you, they don't like using the silicone-based lube, they really are attached to the water-based lube, it's cheaper. These are things that you want to take into account. So common brands, just to make it simple, for the silicone-based lube, the patients really like Uberlube as well as ID Millennium. For the water-based lubes, the ones that fit into appropriate pH and osmolality, brands called Yes, Good Clean Love, and Sliquid. You will probably be asked by patients about parabens. I have a lot of my breast cancer patients will have read about it on the internet. It is thought to be a weakly estrogenic preservative. It's found in KY jelly, Replens, as well as Astroglide. On the internet, patients will read about it being linked to hormone-sensitive cancers. The research evidence has not shown this direct linkage or direct carcinogenesis, but it's also not shown that it's not related. So there are so many paraben-free options that I just tell patients to choose one of those. All of the brands that I listed on the previous slide, those are all paraben-free. So just to be on the safe side, I'll encourage them to seek out those. So let's now move on to non-hormonal management. So patients where they have more moderate or severe vulvovaginal atrophy, where the lubrication, they need more than the lubrication. And these are the vaginal moisturizers. So the two categories are Replens, which is a polycarbophil bioadhesive. And then the second category moisturizers are the hyaluronic acid. I've put here on the next two slides all of the RCTs related to Replens and hyaluronic acid, where they've been compared to estrogen, usually a vaginal estradiol. Overall, the research shows that there is, at the very least, a transient improvement of symptoms of vulvovaginal atrophy. There are some studies which show it may even be equivalent to a vaginal estradiol. Both of these families of products act on the surface of the vaginal epithelium. So when they've done histopathology, it doesn't actually change the tissue permanently. So it doesn't usually affect the vaginal maturation index, but clinically, that's not something that's relevant. We're more looking at the symptoms. And as I mentioned a few slides ago, the Replens is not paraben-free, but the hyaluronic acid products I'm going to mention are paraben-free. So because these are also water-based, you do need to take into account the pH and the osmolality. Companies are not, it's not mandated that they publish this data. So I haven't been able to find it on all of them, but the Replens we know is slightly acidic. Its osmolality is also greater than the 1200. That's the maximum recommended osmolality. Zestica, which is a hyaluronic acid gel, does have a slightly higher pH, so we're more in the menopausal range, but the osmolality is even less than that 380. I've yet to have been able to find anything on Repagyne or Gynatrove, which are also the hyaluronic acid products. So what I'd like to do is tell you what I do, and I really want to emphasize this because I do find in community settings this is not this can be extremely effective, but it's not necessarily used to its kind of maximum effect. I think it's more beneficial than people think. So I start off with the education. So I do an educational pelvic exam and show the patient the difference between the vestibule, which is estrogen as well as androgen sensitive, and then also the vagina. If a woman is experiencing a lot of pain with intercourse, I would recommend that they remove penetration from their sexual repertoire while the woman is going through the healing process. I recommend treating the vestibule, and what we use in our sexual medicine clinic is a moisturizer called Glaxo Base to the vestibule 1 to 2 times a day for 3 months. They can also use, people use coconut oil successfully. Patients really like coconut oil now, it's very trendy. If the hyaluronic acid product that I recommend comes in a gel form, they can also apply that to the vestibule. The Repagyne just comes in a suppository though. We use the hyaluronic acid-based products. We use them as replens, or as you would use an estrogen, so daily for 2 weeks and then 2 to 3 times per week long term. The other, what I find very important with using the non-hormonal treatments is to manage their expectations. So patients, unless you say this, patients will think that it's either PRN or that it's a fast-acting treatment, but it's really not. It does take 3 months to see the optimum effect, and they may not notice any difference for even 6 to 8 weeks. So women where you manage those expectations, and I see very high success rates with following this regimen, and especially the breast cancer patients, they're very motivated to stay away from hormones. I see wonderful success rates. I do have them come back and see me in the office at 3 months. If they have ongoing dyspareunia, then I'll do an exam. We'll see if there is still ongoing atrophy, and assess for a secondary diagnosis if the atrophy has resolved. But the important thing to do is to assess the pelvic floor muscle tone, because women who've been having painful sex prior to coming to see you, they may have an involuntary tension within the pelvic floor. So that would still cause painful intercourse, and then you've treated the atrophy, and the next step may be for them to see a pelvic floor physiotherapist. So now what I'd like to do is to discuss the second issue that I see. And because I run a sexual medicine clinic, patients will come to me, and part of their presenting complaint will be that they have low desire. So because they brought it up, I can very easily discuss that in my office. But I also use that removing penetration from the menu as an entry point to discussing sexual desire and arousal. So patients, or basically the general population, has this understanding of sexual desire as being a spontaneous desire, so that urgency and that hunger. But the way that it's portrayed in the media is not really representative of the experience of the majority of the healthy female population. So what I start off with is explaining that what we see in the magazines and books and in movies is not very common. So this is the traditional female sexual response model, which is a very linear, simple model that shows or suggests that starting with spontaneous desire is normal and common. This then leads to arousal and eventually the goal of penetrative intercourse being orgasm and then resolution. When this was put into practice, though, it was found that this was not what patients were describing. This is not what sexually healthy females were describing. And in fact, if you take this model and apply it to the general female population, you would have about 60 to 70% of women would then be labeled as sexually dysfunctional when they may not see themselves as being sexually dysfunctional. So a physician in Vancouver named Rosemary Besson in the 90s and early 2000s came up with a different model of the female sexual response, which is definitely more representative of the population that we see. And I use this, I actually will go through this in my office. So this is the sexual response cycle. And I'll write this out in my office, and I can do it in under 3 to 4 minutes. So the goal of treating someone with low desire is primarily education. So to tell them the difference between the spontaneous desire we see in the movies compared to responsive desire, which is much more reflective of healthy females. So the goal is to start with is a feeling of neutrality. So where a woman is open, receptive, willing to engage in intimacy. So they may not have that urgency, but they're not avoiding it. And then depending on the reasons they have for engaging in intimacy, and these can either be positive reasons or negative reasons, depending on the stimuli. So the romantic triggers, is it a safe environment? Are there interruptions? The brain will take all of this information and process it. So the brain processing this depends on stress levels, fatigue, depends on distractions, judgmental thoughts, the health of the relationship. If the brain decides that these are all okay and it's romantic, the woman will then turn the corner and develop physical and emotional arousal, and then responsive desire occurs. So this is where desire comes into the sexual encounter, where the woman then has a desire to continue on with the intimate experience. The outcome, if it's a satisfying outcome, will then feed back in to these feelings of neutrality. So the next time she'll be open, willing, and receptive. So you can see if the outcome is not satisfying, so if the woman is having pain related to vulvovaginal atrophy, then the next time it will feed into maybe her not being neutral, to being aversive to intimacy. This will then lead to her reasons for engaging in intimacy being more of the negative reasons. So engaging in intimacy for feelings of guilt, shame, fear of losing a partner, fear of annoying a partner, feels it's her duty as a partner to engage in intimacy. And then it kind of goes around the cycle leading to decreased arousal, decreased desire, and a further negative outcome. So that's why I talk about, while sex is painful, remove it from the menu, and then we'll engage in either other forms of physical intimacy that don't involve penetration. And once the tissue is healthy and elastic, then that can be reintroduced. So what do? I'll draw out that cycle for women. It takes under 3 to 4 minutes. Provide information about the difference between responsive and spontaneous desire. For many people, just that education is all that they need. And that can also be very helpful for the partner to understand that difference as well, so that the partner doesn't feel, if the woman does not have spontaneous desire, doesn't feel rejected or feel unloved. I encourage planned communication with the partner. So this is not in the moment when emotions are high, but to actually have a discussion about what's going on with the vulvovaginal atrophy. During the next 2 to 3 months, let's do other physically affectionate things, but not have penetration. And then I also would start with them reviewing the reasons for intimacy. So to shift from that duty, guilt, obligation to a mindset where they're more approach reasons. And that it's not like that traditional model where the only reason is for orgasm, but thinking about things like emotional closeness, physical bond, a stress relief, to feel loved. There was a study done many years ago where they looked at reasons for engaging in intimacy. And in this study, they actually came up with 240 reasons. So there are so many, and this can be a really nice starting point for someone to work on desire. The other thing, this is a book to recommend if your patient really likes reading. It's by a local psychologist who is called Better Sex Through Mindfulness, using these tools to cultivate desire. And in this book, she talks a lot about the sexual response cycle that I just went through. And also, I'm just going to end here with a study that Dr. Brado, who wrote that book, is doing on breast cancer and sexuality. This study will be going on for the next 2 years. And she's looking at online Zoom sessions comparing mindfulness-based treatments for sexual difficulties compared to the sexual health education. So I'm just going to end here, and really I hope I hope that I accomplished my objective of giving you a very practical approach for both of those things. And I think with the next talk, Dr. Lipkowitz is going to get into all the hormones.
Melanie, that was terrific. Am I on? Can everyone hear me okay? We are a little bit behind, but I think we'll be able to catch up as we move later on into the breaks and lunches. But it's important for us to have the Q&A. Before we start with our first Q&A, I'm going to ask Dr. Moyad to come back online and just take 2 or 3 minutes to summarize his main points. He was cut off because of a technical problem. So if we can bring Mark back on, there he is. A couple of minutes, Mark, and then we'll get into the questions.
So can you hear me okay right now?
I can hear you.
Okay. I apologize. I got cut off, some technical difficulties, that happens. But the good news is when I went back and looked, we got through 70 slides, and my goal was to get through 85. That would have been a record for such a short period of time, and I came this close to my record. I think besides having some last-minute comical slides that Dr. Goldenberg would have enjoyed, including when I took him to a hockey game in Detroit to try to get him to basically leave the Vancouver fan base and join the Detroit fan base. It didn't work, and I had those photos, and trust me, they would have been very, very funny, but I'll show those at another conference. So the only other slides I had left was to argue the fact, essentially, we don't need to bring them up, I have some of them there, was that we didn't talk much about exercise, and it's not that I don't want to talk about exercise, but it's as important right now, as I say in 2020, to talk to breast and prostate cancer patients about 2 issues regarding the diet. And we focused on both. That's quantity and quality. And that is impacting our randomized trials. So to have that discussion about quantity and quality, for some people it's quantity, for others it's quality, many people it's both. It's just as important as exercise, because in randomized trials where people just cut back on calories of a variety of types or cut back up to a small degree and exercised a lot, the weight loss has been the same, the adipose tissue loss, the lean muscle mass maintenance. And so caloric control, to me, is really becoming the big topic. We're getting plenty of research now on exercise that is allowing me to advertise it more and more, whether it was the latest meta-analysis that showed that it was equivalent or superior to anything else we're using in cancer for cancer-related fatigue, CRF, which is a massive problem. That was the largest meta-analysis ever conducted looking against supplements and pharmaceutical or prescription agents, and exercise is working as well as any of those. But the primary reason I talk exercise, the way I talk exercise with people who have been affected by cancer or not, is similar. I think that we need to do a better job of focusing on the mental health aspects of exercise. We can argue all day long until the last days that I'm around whether or not it truly will impact the progression of a cancer. But there's little argument today, if we look at the data, of an acronym I tried to put together for patients and healthcare professionals, which is called the impact of exercise on SAD, sick, hip. And people say, SAD, sick, hip, what does that acronym mean? There's little doubt that the reason I promote exercise so much, if it's walking, swimming, whatever patients like, is its impact on stress. This is the sad part. Its impact on stress, anxiety, depression. SI is suicidal ideation, something I talk about the young population all the time. It reboots the brain in a lot of ways. Again, it's not going to be it's not going to be the panacea to the problem. But stress, anxiety, depression, suicidal ideation, which is an uncomfortable topic to talk about, we have to talk about it. And in the sick part, the C is catastrophizing. It is very easy with a cancer diagnosis. It's very easy within a pandemic. It's very easy when you get a lot of negative information or bad news to start catastrophizing, where one negative thought begets another negative thought, begets another negative thought. Oh, I got this diagnosis, my PSA, what happens then if I get a metastasis? If I get a metastasis, will they have a drug? Will there be a clinical trial? I see so many people go down that path. What exercise does also, and again, it's not the panacea, but that rebooting prospect, that rebooting effect also can impact catastrophizing. And that's why we always kind of joke around. I used to joke with my kids, and now I joke with my healthcare colleagues whenever someone gets angry. I say, look, you're only one workout away from being in a good mood. And there's a lot of truth to that. That's that runner's high effect. Now, stress, anxiety, depression, suicidal ideation, catastrophizing, that should be enough to promote exercise of any type, right? But the newest word is hippocampus. And hippocampus are found in two areas of the temporal lobe. It stores memory. And what we see is when you utilize exercise, that area does not atrophy. So the brain is very sensitive in a few areas to exercise and blood flow. And the hippocampus, the memory center, is one of those, which is why it didn't surprise me in the United States that the American Academy of Neurology last year changed their clinical guidelines to now recommend exercise for mild cognitive impairment, making it arguably the only thing they can recommend out there medically for mild cognitive impairment to slow the progression of that into potentially dementia. And when we talk androgen deprivation, or we talk in breast cancer of all the side effects of meds, just take androgen deprivation for a second. Virtually every single side effect that we touch upon from A to Z, almost all of them are impacted favorably or reduced or managed a little bit by physical activity. But mental health is probably the one that I wish would receive the most attention. And so I go back to my summary points, which is when in doubt, heart healthy is breast healthy. When in doubt, heart healthy is mind healthy. When in doubt, heart healthy is prostate healthy, whether you have a prostate or not. And so that is the first do no harm approach. That ultimately, if we can change a person's heart health and mind health, regardless of where these clinical trials go, then everybody benefits overall. So I have something called the 5 Bs. I just want patients to work on 5 Bs with their diet and exercise, and those are 5 tangibles. So B is BMI or belly, so that's their weight. The rest of the Bs are simple. They can work with their GP, blood cholesterol, blood pressure, blood sugar, and the last one is brain health. So they should be happy making these changes. If I can get those 5 Bs going and moving in the right direction, regardless of the diet, regardless of their lifestyle changes, in general, you see favorability. Just like we've seen in the randomized trials in breast cancer and prostate, when lifestyle changes affect those 5 Bs, we think it might affect progression. And if it doesn't impact progression, then at least it can affect quality and quantity of life. The last 2 points I wanted to end up with in my slides that you weren't able to see is you'll see a lot of papers that we've written about an acronym called SAM. The reason we called the acronym SAM is it's sort of a good go-to point with patients in breast and prostate cancer. I find it interesting that in 2020, we have over 100 clinical trials right now on, I'm not promoting these drugs, but it gives you an idea of looking at the big picture. Statins are cholesterol lowering, especially in prostate cancer right now, and the favorable data we're seeing overall in a variety of clinical stages potentially. Aspirin I talked about and potentially qualifying, and we have to wait for that data. And the final one, M, is metformin. The reason I find those so fascinating is all 3 of those come from a quote-unquote natural source, and all of them are generic in the United States and now Canada, I believe. So statins came from a fungus, aspirin came from willow bark, metformin came from the French lilac, and all of them are immersed in looking at side effects or reducing issues, ancillary issues in prostate and breast cancer patients. We know metformin now is the #1 recommended product to reduce the risk of going from prediabetes to type 2 diabetes. It's generic. It's in a phase 3 trial in breast cancer. The patients have lost weight on that drug. We are focusing on 3 heart healthy generics that came from natural sources is kind of a global way of looking how we should approach this when it comes to supplements. My final points are, please never in your practice generalize supplements like I see this all the time. Supplements are all good or they're all bad. No, they're just like medications. They just have some different rules. Some are incredible in certain medical situations. Some don't belong in other situations, as we talked about, and some are very neutral. But there are plenty of supplements out there that are being utilized in medical situations with level 1 evidence or level 2 evidence. And there are plenty of supplements that we should discourage, just like medications. But one of the biggest ways I see clinicians trip themselves up is when they generalize too much about the category, and patients are well aware that this is a category that medical professionals don't get enough education on. My final point is lifestyle changes always need more love. And what I mean by that is it's very easy to become absolutely obsessed with a pill and a product over-the-counter prescription. But lifestyle changes, as they get more data, really surprise me how well they work in certain situations. And I'll leave you with one that I had as a slide that often gets missed because we don't talk about it. Metformin and metformin diabetes prevention program. There were 3 groups in that trial: placebo, metformin, but there was a third group that nobody knew about. It was called the lifestyle intervention group. Patients reduced their caloric intake by about 400 to 450 calories a day, and they essentially exercised about 30 minutes a day. Anyway, New England Journal of Medicine publishes this data. It shows that metformin reduces the risk of type 2 diabetes by 31% over placebo. Everyone gets hyper, they get excited. What got missed in that clinical trial is the lifestyle group reduced the risk of type 2 diabetes by 58%. So it statistically significantly beat the drug, not only in terms of efficacy, but also in terms of safety. So I get excited about all these meds. I get excited about drug repurposing. I'm very excited about supplement and drug repurposing. But at the end of the day, patients making lifestyle changes not only improves their mental and physical health, but we will ultimately find, I believe, like we have with Viagra, like we have with other drugs, that patients who are more physically active, it actually makes their medications work more effectively. So with that, I was going to show my last slide of Dr. Goldenberg and show him that he's my new best friend from Vancouver, and I was going to placate him and basically be a little bit obsequious, but truthfully, it's always an honor working with you, Dr. Goldenberg, and I know we were trying to get this conference going, and I'm really sad that we couldn't actually do this in person, but maybe one day, but it's always an honor to work with you, and I appreciate this time.
Thank you, Mark. Appreciate that. And I'm always going to be a Vancouver Canuck fan. No way you're going to get me to shift to Detroit. Okay, well, that's terrific. Before you go, Mark, there were a couple of questions that were directed at vitamin D. I think I'll read those to you. And is there any role for measuring vitamin D levels, or should we just tell folks to take 1,000 to 2,000 IU per day for bone health? And the second is, how much calcium and vitamin D supplements per day for breast cancer patients treated by surgery, chemo, radiation, and hormone therapy?
Well, the answer to the first question you can do from diet. The recommended daily allowance from calcium and vitamin D in the general population is similar right now in breast cancer. The problem is getting people to that point. And it's based on age too, whether it's 1,000 to 1,200 to 1,300 milligrams of calcium and 600 to 800 IU of vitamin D based on age. The older age, slightly more requirement. And it's possible to get there from diet. It really is today, because the message is everything's being fortified. And I'm not trying to downplay that importance of calcium and vitamin D. It is an absolute must to work with a dietitian, work with a food diary, and try first to get there from the fortified dietary sources. And if you need supplements, that's great. Ultimately, the decision to go to 2,000 or 1,500 will come off of randomized trials. But as the doctor mentioned before, there's so many pieces to bone loss. There's the physical activity portion, right? There's whether or not they're on hormone deprivation. There's the measurement of bone loss. But one thing that gets missed in the exercise category that's getting a lot of attention is resistance exercise. It does seem that with and without hormone, resistance exercise is providing a quantifiable improvement in bone mineral density, but that's going to need help. I think it helps make the drugs work better. I don't think it will ever replace a drug. But when you add all those little components together, calcium and vitamin D is important, but not necessarily overwhelmingly more important then doing upper and lower body resistance exercises, having a DEXA scan done, and working on everything else that great talk gave and the others great talk. I knew the vitamin D portion of my talk would give a little controversy. We're not saying people shouldn't be screened, especially in breast and prostate cancer, where we're relying on some kind of hormonal manipulation and hormonal deprivation. Still, screening is adequate. What I'm saying is the importance of screening with vitamin D, though, as the population is being exposed to more and more, I think is becoming less critical. The problem that we're having in clinical trials in breast and prostate, you might find fascinating, including the trial from Calgary, which was just a population trial of the elderly. It was very difficult to find people who had 30 nanomoles per liter or less, or in the American system, about 12 or less. It was very hard to find people at such a low number anymore like we used to see, because people are supplementing and doing all these things. My multivitamin doubled their vitamin D amount in the past year to 1,000 IU, just on a multivitamin pill. All of my milk alternatives have doubled the amount of vitamin D. All my cereals have added some quantity of vitamin D. So we're not saying that the test is not important in this patient population once in a while, but it's just a piece of the larger puzzle used to assess bone mineral density and bone health. It's not the make or break test that people have made it out to be, because it's subject to a lot of potential changes based on inflammation, based on the progression of the disease, based on the fact that it acts as a negative acute phase reactant. So outside of, in the general population, the vitamin D test is going to struggle in terms of getting approval one day for general health out there, in terms of having everyone just go in unless they've got a bone mineral density risk issue, serious risk issue.
So there's very few indication for actually doing the measuring vitamin D levels.
There's so few indications, so many, this year I call vitamin D the year of disappointment. The D is disappointment. It has failed almost in every major randomized trial that we thought it would work, in blood pressure, in depression, in preventing type 2 diabetes. Take a look at the New England Journal of Medicine and JAMA this year. It's failed almost every major trial. Now, that doesn't mean it won't help potentially in cancer. It just means that we learned this lesson from selenium and vitamin E. We thought more was better and there could be no catch. It turned out more was not better and actually potentially caused harm. And I'll give you an example of people who work in urology out there. MD Anderson just finished a consecutive look at their bladder cancer patients, and they found out that after being treated by BCG and other treatments, there was an increased risk of recurrence by using folic acid supplementation separately from getting folic acid in the diet. So we're not learning right now that more is better in breast and prostate cancer. We're learning that maybe they have a role in reducing side effects, but in terms of the disease process itself, there are people in Canada right now in the United States, just so you know, you can look at this data on PubMed. They're actually constructing questionnaires that challenge vitamin D blood testing, in the sense that they believe that they can develop a validated questionnaire with 10 questions, and based on how you answer them, they can almost with 90% accuracy guess your vitamin D level. And so they're trying to save money, because in our Medicare database, it was one of the top 5 recommended tests, for example, last year in the United States. It's costing a fortune. But vitamin D is predictable based on age, based on how much weight you gain, based on whether or not you smoke, certain drugs that you take. And so I think some of these questionnaires will be used more in the general population in the future, rather than blood testing everybody. Okay. Long answer to a short question, but it's a highly controversial issue.
We'll move right along now to the male sexual issues with respect to prostate cancer patients. I'd like to introduce my junior colleague, Ryan Flanagan, who trained with us and then went to New York to do a fellowship at Cornell and Memorial Sloan Kettering. And since coming back on faculty at UBC, he's developed a very strong surgeon-scientist career. And today he's going to speak to us on the sexual issues for prostate cancer patients. Ryan Flanagan, go ahead, Ryan.
Great, thanks so much. My name is Ryan Flanagan, and I'll be talking to you a little bit about sexual dysfunction and basically a bit of a guideline for managing these patients after prostate cancer treatment. Okay, so some of my disclosures, I have several research grants with multiple agencies that listed there, and have received either speaking honorariums or educational grants from Platin Labs, Cesaris, and Boston Scientific. And this shouldn't have an impact on today's talk, and I won't be discussing any penile implant brand names when we get to that section. So the objectives are to talk about sexual dysfunction after prostate cancer, what kinds of sexual dysfunction can patients have, and then some management strategies to help the management of these patients that are suffering from the side effects. And then also talk a little bit about resources available to healthcare providers and patients to help navigate some of these troubles. So no matter what form of treatment for prostate cancer, there's potential for impact on sexual function. Now, we're most familiar with the impact on the potential nerves that are responsible for erections. So these are the cavernosal nerves, and as you can see, the yellow nerves in this anatomical drawing come down from the lumbar and sacral plexus. They go adjacent to the rectum, behind the bladder, and then hug the shoulders of the prostate before they enter into the base of the penis. This transmits the signal from the brain and the spinal cord to the penis to achieve an erection. And these can be impacted by surgery, whether that's having to carefully dissect off these nerves, or in some cases, if the tumor is on that side and aggressive, the surgeon will have to take these nerves for the primary goal of having negative surgical margins and a curative surgery. Similarly, with radiation therapy, whether it's external beam therapy or brachytherapy, there's a potential for damage to some of these nerves. With external beam radiation therapy, the main dose of the radiation is concentrated within the prostate, but as you can see in the picture in the top right corner, there is a gradual decrease in the radiation dose as you get farther from the prostate center, and therefore the nerves are exposed to this. Similarly, with the brachytherapy, each of these seeds has a zone associated with damaging radiation purposefully to treat the prostate cancer, but it can also impact the nerves towards the edges. So this is kind of the base to the biological impacts on some of the sexual function, but there are also other potential forms of sexual dysfunction, both biologically and some of the psychological and social implications from these treatments. So we'll be talking about each of these here today. So erectile function dysfunction is the most commonly discussed and well-versed. It is largely impactful for patients as well as their partners. But there's also others. So anejaculation. Now, this is the condition where there is no semen at the time of climax or orgasm. So this is particularly relevant in the surgery group, but also a little bit in radiation, and we'll get into this shortly. Now, I just want to point out that ejaculation is a different physiological process than orgasm. Ejaculation is the production of fluid that's emitted throughout the penis, where orgasm is the sensory experience associated with climax, associated with sexual activity. Now, dysorgasmia, or painful orgasm, can be a side effect that some people experience. Climacturia, this is the leakage of urine at the time of orgasm or climax. And there's also another term called arousal incontinence. This is leakage of urine throughout sexual activity or stimulation prior to climax. Some patients observe penile shortening, but up to 15% of men will observe penile curvature after treatment for prostate cancer, otherwise known as Peyronie's disease. And there's also significant disruptions to intimacy and masculinity, and a lot of the other psychosocial parameters associated with self-identity, sexual identity for an individual, and that can have implications for a relationship with their partner if they're partnered. Now, if we break this down by treatment modality to try to get a little bit better idea of the flavor of side effects associated with each of the treatments, if we look at radical prostatectomies or surgery, certainly erectile dysfunction, as we mentioned, is one of the primary forms of sexual dysfunction that gets a lot of airtime, and rightly so. If you look at the top graph on the right side, this is just pulled from a study that looks at the number of individuals that will likely regain either full erections, which is the top curve, and corresponds to about 60% of men, partial or recently diminished or partial erections, which is about 20% at the lower end. Now, the other important thing to look at this curve is the time course that people have these side effects and some recovery of function. So time point 0 on the x-axis is time of surgery. And as you'll see, as you go further out, 12 months, 24 months, 36, all the way to 60 months or 5 years, you see an increase in sexual function, or erections specifically in this case, and then the curve flattens. We typically think right around 2 years, 0 to 2 years is where most of the improvement occurs, and then there's small marginal benefits between 2 to 4 years, and then typically the curve flattens, where they'll start to have worsening erectile function over time associated with an age-related decline. Similar results were shown in a study published in New England Journal of Medicine from Donovan in 2016. On the bottom, if you look at the red group, radical prostatectomy, you'll see that immediately after, so 6-month time point is when they measured the erectile firmness, and that was at the all-time low for the surgery group. And then similar to the study above, over the first 24 to 48 months, there was a gradual improvement before it leveled off, and then a slight decrease between 5 and 6 years, again associated with an age-related decline. So along with erectile dysfunction, men can experience penile shortening. There's some debate as to the exact pathophysiology of how this is happening, but we do know that there's some degree of fibrosis that sets in within the cavernosal muscle, and the elasticity is lost to a certain extent, particularly if they're not getting frequent and active erections. Peyronie's disease, as I mentioned, about 15% after all treatment modalities for prostate cancer, and is currently probably understudied, but more reports are coming out. And ejaculation, by convention, all men with radical prostatectomy will no longer produce semen at the time of climax. Okay, they'll still experience orgasm, but they won't have any fluid produced. For some men, this is not a problem at all, and for others, this is somewhat bothersome. Now, of this group, about 15% of men will have some pain at the time of orgasm, and it's typically worse in the initial phases, and then with time, this typically gets better and better. There's also some other options to try to help improve this, like using an alpha blocker to help relax some of those muscles. We think it might be related to spasm, tension within the pelvic floor muscles associated with contractions and orgasm. Climacturia can also be another bothersome one. As I mentioned, this is the leakage of urine at the time of climax, or arousal incontinence prior to climax. Now, all of these things can be bothersome in their own, and I would classify a lot of these as biological impacts of sexual function, but there's also a lot of repercussions and ripple effect to psychosocial dysfunction and morbidity associated with these. So a lot of men identify with their sexual identity and their ability to perform and engage in sexual activity. Masculinity is heavily tied in with this, and that also has an impact on their intimacy and how they share experiences with their partner, whether that's sexual intimacy, or that can also have impacts on other forms of intimacy if it is quite bothersome. There's typically not a big impact on arousal unless there is a lot of anxiety associated with it. Something that we often see is if the erections aren't working well, the individual might be frustrated or feeling a little bit hopeless about being sexually active, and that can have a negative implication on the arousal. So it ends up being a little bit of a circular kind of dynamic, where if you can get the erections working a little bit better, then sometimes that will also help the arousal. Now, if we look at external beam radiation therapy, so if we look at the graph here on the right, Radical radiotherapy is the yellow or orange line. And again, there is a dip in the first 6 months, a little bit quicker recovery than the surgery group at up to 12 months. And then there's a gradual stepwise decline over time between 12 and 72 months. So that is also a factor that a lot of men are experiencing and need management with. Similarly, implications of the penile shortening are a thing here as well, and Peyronie's disease. However, with respect to the ejaculation and the orgasm, they'll often have decreased volume of ejaculate and semen, but not always complete loss. Sometimes if there's a lot of fibrosis or scarring of the ejaculatory ducts, they could result in complete lack of semen or an ejaculation. But most often it's just a reduced volume. Similarly, some of the fibrosis that sets into the prostate can also result in painful orgasm. And similarly, just like surgery, some of the psychosocial implications and impact can also be present here for these individuals, and is basically across all the treatment modalities. Certainly, one point worth noting is with androgen deprivation therapy, the arousal can certainly be drastically lower. We know that testosterone is one of the major drivers for the experience of arousal. People describe arousal as both cognitive and visceral. So cognitive means that we think about our partner, we're attracted to our partner, we want to be sexually active with our partner, where visceral is more of the feeling that people describe in their belly, or that feeling that's somewhat dissociated from the cognitive or the thinking process of being aroused. With low testosterone, that visceral arousal is drastically reduced, but people can still obviously maintain the cognitive arousal of thinking their partner is attractive and wanting to be sexually intimate with them. And similarly with brachytherapy compared to external beam therapy, there can also be impacts on erectile dysfunction and all of the other forms of dysfunction. Certainly the painful orgasm can be more noted up front, in the period of time following insertion of the beads, and then that typically gets better for most men. This is a study by Dr. Keyes in 2015 looking at the impact of brachytherapy on erectile function. So if you look at the top graph, these were all the men that had really good erections going into therapy. So if you look at the baseline bar, the pair on the left side in the top graph, 100% of men have full erections. Now, let's just see if my lines made it in here. Nope, they didn't. Okay, so the left bar are men that had ADT. So you'll see two pairs of bars at each time point. The left of the two received ADT, and the right side of the two bars did not receive ADT. So you'll see there's a big downward swing in those receiving brachytherapy and ADT. And it drops way down at 1.5 months and then recovers over the next 2 years. And then after 2 years, the ADT and the non-ADT group appear to be quite similar. If you look at the bottom graph, these were men that had mediocre erections to start with. So they're a little bit borderline already. And as you can see, they're very close to falling off the cliff with any kind of a push of additional therapy that could have these side effects from the beginning. So there's a much more drastic decrease in erectile function for both the ADT and the non-ADT group, but obviously more obvious in the ADT group. Now, if we look at androgen deprivation therapy on itself, it can have an implication for erectile dysfunction. Testosterone is not absolutely necessary for erections, but certainly does help with erections, although there's some controversy over certain thresholds and levels. But certainly if you're at a very low level of testosterone, this can be a major factor. It can also impact penile shortening. We know that with low testosterone, there can be increased levels of fibrosis in the cavernosal smooth muscle. Low testosterone is a risk factor for Peyronie's disease, and it can also impact a decreased volume of ejaculate and a decreased intensity of orgasm. Psychosocial impact, similar to all of these, and perhaps even more drastic in some regards, particularly with arousal, as we were previously discussing. Now, some of the approaches, so we want to talk to our patients about sexual adaptation and being versatile and open to the new changes that they have and navigating forward. Communication is really critical and has been shown to be a really critical factor for sexual satisfaction across multiple studies. Refocusing intimacy with the patient's partner. So not everything has to be about penetrative intercourse. There's a lot of other ways to maintain sexual intimacy that can be very satisfying for couples. Managing any ejaculatory dysfunction, erectile function, and obviously reaching out to survivorship programs that have put a lot of effort into creating content and experience for the patients. So the concept of sexual rehabilitation, it really goes around the concept of gaining knowledge, being aware of the potential side effects or the side effects that they're currently experiencing, and having the knowledge to empower them to try new things, be aware of the situation, align realistic expectations based upon what will likely happen. Is also about building skills, so coping skills, communication skills. A lot of men prior to this have had normal sexual function. They've never had to have these discussions or communicate with their partner when something's not working. So this can be a really big transition for some of them, and they might not have the skill set to move that forward. So introducing some of these can be quite helpful. Also, debunking some of the myths that we're used to can be really helpful. Some people think that this is the end of the road and they're supposed to hang up the skates after they have their prostate treated. But that's, obviously not necessary for people, as there's a lot of different treatment options. And obviously, being informed on new ways to be intimate and sexually active is also quite important here. As I mentioned, communication is one of the most predictive factors on sexual satisfaction amongst coupled patients. And we really advocate for communicating what is working for individuals and what is not working. And therefore, there's full transparency amongst relationships that can be quite helpful. Similarly, with intimacy, again, it doesn't have to be just about penetrative intercourse. It's not an all or nothing thing. Sometimes it's adapting to find other ways to be sexually intimate, or even focusing on non-sexual forms of intimacy that are important. Now, the inability to achieve orgasm can be one of the most challenging things to treat, I find, within sexual medicine. There's certainly some off-label medications, such as cabergoline, which may show some improvement if these individuals can't achieve orgasm. There's also been some improvements with use of PDE5 inhibitors described. Mindfulness-based therapies are also really important. The lack of ejaculation and fluid is something that is generally not a variable that can be manipulated particularly easy, especially not at all in the surgery group. Painful orgasm, again, I mentioned, is about 15% of men. There's been some data to suggest that alpha blocker therapy like Flomax or tamsulosin can be helpful for these individuals, and certainly consideration of pelvic floor physiotherapy and biofeedback can also be helpful. And certainly just time. It takes time for everything to heal and to find a new homeostasis, so to speak, after treatment, and that can be quite helpful. Having urinary leakage at the time of climax or during sexual activity can be quite distressful for patients and their partners. So there's a few things that we always encourage our patients to do that might be able to help this situation. One, obviously empty your bladder as best you can before any sexual activity. That will decrease the risk. Optimize your environment. So if you're in the bedroom, put down a towel so you're not worried about causing any damage to the bedding or the bed or anything like that. Move sexual activity to an environment that's more conducive, into a bathroom or a shower. Working on pelvic floor physiotherapy, Kegel exercises to help strengthen the remaining external sphincter can be helpful here. And obviously biofeedback incorporated within that can be helpful. There's also devices that you can use. This is one example called a Eurostop device. And basically it's a latex band that goes around the penis, and at the base, you can tighten it. That compresses the urethra and prevents leakage of urine during sexual activity. It usually doesn't interfere with the erection. You place it once the individuals receive the erection. And as you can see from this particular study at the bottom, there's a leftward shift of patients that had some leakage. Most of them resulted in no leakage. If they had a lot of leakage, they resulted in much less leakage. And the amount of partner distress and patient distress also decreased significantly, particularly amongst partner distress if you look at the right column, going from 61% pre-treatment all the way down to 11%. Now, if things are particularly bad, surgery might be the option, and usually in this case, patients are also having stress urinary incontinence throughout the day, which can be bothersome. They might have to use multiple pads. Usually this is the point where we tried all the conservative options and they're still having a lot of morbidity and distress. So depending on the individual, a male urethral sling or a urinary sphincter could be quite helpful in this situation. The concept of penile rehabilitation. So this is based on the premise of, use it or lose it. After any kind of treatment and there's a loss of erections for a period of time, we know that with ongoing time, that cavernosal smooth muscle will become more and more fibrotic and have less elasticity and ability to expand and trap that blood in. So therefore, you have a lot higher risk of having sustained venous leak that's not responsive to therapies, even after the initial nerve insult. So this concept is about stimulating regular erections. We say at least 3 per week, and whatever form of treatment that's necessary to stimulate those erections is okay by us. So if people are responsive to PDE5 inhibitors, such as sildenafil, fantastic, use those. If you don't need them, even better. If you need penile injection therapy or a vacuum pump, then those can be facilitated. But we really encourage patients to get on this very soon after. Ideally, it would be within 6 weeks of treatment, either radiation therapy or after surgery. Most of the studies looking at the outcomes suggest that there is a big improvement in long-term erectile function amongst those patients that have used penile rehabilitation. So it's something worth considering and encouraging our patients to take part in. Now, in the final section here, managing erectile dysfunction, we typically go through a systematic stepwise approach. So from non-invasive to most invasive, pills such as sildenafil, tadalafil, and vardenafil can be quite helpful. They're convenient to use. Typically, you take them 1 to 2 hours before you want to stimulate an erection. Vardenafil and sildenafil last somewhere between 4 and 8 hours. Tadalafil lasts a little bit longer, with peak half-lives being around 18 hours. And may stay in the system with some effect up to 24 to 36 hours. They're moderately expensive, although some have become generic with sildenafil recently. So some of the costs are coming down. There are some potential risks of side effects. Some people are more sensitive to this than others. Headaches, flushing, stomach upset, or muscle pains, or blurry vision are some of those that people will complain of. But start with a low dose and slowly titrate up and see if we can find a sweet spot where they have good function and low side effects. Muse therapy, this is one of the less commonly used techniques just because it's a little bit cumbersome to place the medication in the urethra. But one of the great things about it is that even if there's compromise of the nerves following treatment, this medication acts locally. So you don't necessarily need fully intact nerves for the medication to work. One of the other downsides is it can cause a little bit of discomfort or discomfort to the partner if some of that medication leaks out into the receiving orifice. They can also be a little bit on the expensive side relative to the pills. Injection therapy is one of our mainstay therapies. This is a really effective option for a lot of men. The concept is obviously very scary for most men that walk through the door, but nearly everybody that we treat with it tells us after they use the injections that the anticipation was far worse than the actual experience of putting a little needle in. So we typically use a small 1 cc insulin needle between 28 and 30 gauge. And typically after an injection, 5 to 10 minutes later, they'll get a good strong erection once we find the correct dose for them. And we'll titrate that dose so they have an erection lasting somewhere between 30 and 60 minutes, sometimes a little bit longer. The main risk with this is development of priapism, where an erection lasts longer than desired, greater than 4 hours, and that can have a negative impact on the muscle health. But if they're appropriately trained and properly dose titrated, the risk of this is usually less than 1% in any established program. It's also fairly cost effective. A vial of about 5 cc's is approximately $120, and that, depending on the dose, will last most people for several months. Vacuum therapy can also be another effective treatment. And for these individuals that don't want systemic side effects or to take medications, it works locally. It does not require nerve function to be intact, similar to the injections. And the cost, once you front the $300 to $500, doesn't cost anything beyond that. One of the downsides is the shaft may be firm beyond the constriction band, but proximal to that, it's potentially soft and just requires some adjustment to use these effectively. And finally, penile implant surgery. These can be quite effective with sexual satisfaction rates over 90% for both patients and partners. Typically, we put in this 3-piece device where there's a fluid reservoir we tuck in by the bladder, a pump that we place in the scrotum, and then 2 cylinders. This works like a hydraulic system. Patient pushes the pump, fluid moves from the reservoir into the tube, and the penis becomes erect and firm. There's also different kinds of devices, either a 2-piece, which the reservoir is built within the cylinders, or a malleable if patients have poor dexterity and can't use the pump. All can be very effective in achieving a very reliable, firm erection. It is irreversible, so once we put one in, it destroys the natural erection tissue. So typically we do this once we've failed all of our conservative options. So in terms of accessing additional care, the PCSE Sexual Rehab Program and Clinic has nurse clinicians to provide some of this care. We have education material prepared and available for patients and available for healthcare providers. And they're integrated for both biological interventions such as medications, devices, surgical therapy with consults to surgeons that do this procedure, such as the penile implant, as well as psychosocial training and counseling. We have 3 locations currently in the province: Prince George, Victoria, and Vancouver, with 3 different specialized nurse clinicians that have been highly trained in sexual health, and here are administrative leads. This clinic offers either traditional one-on-one clinic interactions in person or through Zoom. We also have liaised with a Toronto group at Princess Margaret called the Share E Clinic, where they have an online platform that delivers specialized care based on the patient's specific situation through various modules, and they can interact with the healthcare provider through the app, or patients can access both our one-on-one clinic and have access to the Share E online platform for additional education, and we call this our hybrid clinic. So in summary, prostate cancer can impact both in the partners. Sexual dysfunction can impact biological, psychological, and social aspects of individuals' well-being. And there's lots of resources through the PCSE program for patients and healthcare providers. Thank you very much.
Thanks, Ryan. Very comprehensive review. And segueing from your introduction of the PCSE program, invited Monita Sundar, who is our provincial program manager for the program, to give us a brief overview of the program itself and what you can offer to your patients. Manita has a Master of Arts in Gerontology from SFU and has been a tremendous asset to our program since she joined us. So, Manita, it's all yours.
Great. Thank you, Dr. Goldenberg, for that introduction. So as far as disclosures go, I've had a speaker honorarium received from Chair Sarah from a past speaking event. And my main objective today is really to describe the prostate cancer supportive care program to all of you today in hopes that you'll be able to recommend our program to prostate cancer patients. So support for our program has been provided from a number of different government and non-government organizations. Specifically, I really want to acknowledge the Special Services Committee. This is a joint collaboration between the Ministry of Health and the Doctors of BC. They were very instrumental in providing us with startup funding so we could implement our program in January 2013. And then in March of 2017, the Ministry of Health gave us a substantial amount of funding to expand our program across the province. We were able to achieve this objective by collaborating with BC Cancer, and therefore we've expanded our programs to 3 of their sites, and those include Victoria, Kelowna, and Prince George. So the Prostate Cancer Supportive Care Program is really designed to provide supportive care both for patients and their partners from the time of diagnosis and onwards. It is both a supportive care program and a research initiative. Over the years, not only have we partnered with other groups across Canada to assist in research, but we're also examining our own metrics in our program to assess health outcomes for patients. The program is delivered in a modular approach. Patients really just choose modules of interest. We believe that knowledge is empowering, and education sessions can really help answer questions and relieve the stress and anxiety that they experience when they get their cancer diagnosis. As far as patients coming into the program, patients can self-refer, or alternatively, physicians and any allied healthcare professional can refer patients to the program. So basically how it works, the patient registers officially into the program. This is done by one of our program coordinators at one of our 4 sites. And this involves collecting demographic and medical history on the patient. There are 7 modules available, but patients don't have to participate in modules sequentially, just because not all of the modules would be pertinent to them. So they really just join modules that are more specific to their needs. Partners and family members are also invited to all of the sessions, and generally our modules are offered in person and virtually, but due to the pandemic, only a limited number of sites are actually able to see patients in person for their clinic. So I'm going to just walk you through briefly all of our 7 modules that we offer. And just to keep in mind, like how patients access the various modules is really dependent on where they're at with their prostate cancer journey and the state of readiness. So for some individuals, it might take some time to move forward with recovery. But the key thing for patients to remember is that they should be proactive to ensure the most optimal state of recovery and adjustment. So module 1, this is our first module, and this is specific to newly diagnosed prostate cancer patients. This education session is presented by a urologist and a radiation oncologist. And what they do is they talk right down to the bare bones of what is prostate cancer and how does a patient get diagnosed with prostate cancer, who's at risk. They also talk about both of the treatment options, so surgery and radiation therapy, and all of the possible side effects that may occur with choosing treatment. So we use a very non-biased approach. We really simply just present the information so that patients are educated and they understand all of the treatment options and the side effects from the treatment. Towards the end of the education session for that evening, one of our program coordinator is there to give an overview of all of the modules offered in the program. So much what, like I'm doing for you today, they just flesh out all of the different modules that's available. So Module 2, managing the impact of prostate cancer treatments on sexual function and intimacy. Dr. Flanagan touched upon this briefly. This is actually the most attended module in our entire program. We feel that prostate cancer is a couple's disease and that both prostate cancer patients and partners are impacted. We know that prostate cancer treatments impact sexual function. To what degree really depends on a number of factors: the age of the man, if there were sexual function difficulties prior to prostate cancer treatment, and the type of treatment that they chose. But with that said, there are two ways that you can really take advantage of our module here. The first is our sexual rehabilitation clinic, and as Dr. Flanagan mentioned, there is a monthly education session that is available for patients, and then they come into our clinic and we offer 7 one-on-one clinic appointments over a 2-year span with our sexual health nurse. And this is really giving them personalized care, and it gives them the opportunity to discuss the impact of treatment on sexual function and intimacy. A lot of the information in the education is general to the various treatments and strategies for coping with sexual dysfunction. So when patients are coming in and attending the clinic with our sexual health nurses, this allows them to have a personalized plan of care. The second option is the Share Clinic. Again, this is an online platform that patients can take advantage of. It was developed in Toronto. And this is a really good option for patients if they prefer to learn at their own pace. And in order for them to participate, they do require a specific code and just to get online. But this can be readily available by one of our program coordinators across the province. We really strongly recommend combining the two options, so joining the sexual rehabilitation clinic as well as partaking in the Share Clinic. And this gives them an opportunity to, well, it actually complements the efforts that we have for them and the education and resources needed for patients and their sexual adaptation process. So Module 3, it's our lifestyle management module. It actually branches out into 2 different themes. The first is exercise, and we did hear Dr. Moya talk about the importance of exercise. So this really gives patients a great opportunity to be able to come into our exercise clinic. We have an exercise physiologist who creates a personal exercise prescription for them specifically according to their abilities. So if they've never exercised in their life, this is an opportunity for them to come in and start getting active. And if they are regularly active, again, another great way to meet with an exercise physiologist and try and see how we can challenge increasing their physical fitness. So what's involved here is a mandatory education session at the outset, and then we have 5 appointments over the course of a year. And each time they're coming into clinic, they're constantly getting assessed and making sure that are they able to achieve the prescription that was developed for them? If not, why not? Is it too hard? And then, the prescription can be easily changed to be decreased, or if it's too easy, it can definitely be increased and make it more challenging for the patient. So a really good opportunity for patients to take advantage of. The second part of the lifestyle management is nutrition. And this module, we offer a monthly education session. And this education session is specific for nutrition for prostate cancer patients. So what are foods that patients should be eating now that they've got this prostate cancer diagnosis? So this session is delivered by a registered dietitian. And we also offer one-on-one appointments, whether it's in person or virtual. And this gives them another great opportunity to really kind of understand how they can improve their diet, whether it's just a quick nutritional checkup, if you wanted to get some fresh ideas on how to eat better, or if you're starting to try a new medical diet or a new special diet. This is a great opportunity for patients to take advantage of our registered dietitian. Our module 4 is called Recognition and Management of Treatment-Related Side Effects of Androgen Deprivation Therapy. It's a big mouthful of a title, but basically this is a preemptive education session about hormone therapy. And as we know, there's a lot of possible side effects with hormone therapy. Not to say that patients are going to get all of the side effects, but this education session really kind of points out all of the different side effects they might be encountering, and we also give them some strategies on how to reduce the side effects. So again, this is an education session that's delivered by nurses, and we've also added an ADT clinic that's delivered by a nurse practitioner. So you can see him if your patients are happening to have really bad side effects from being on ADT, and we can set up appointments and help them, give them some advice on how to manage those side effects. Module 4 is our pelvic floor physiotherapy module. This module really focuses on helping people understand typical bladder and bowel control mechanisms and how treatment for prostate cancer can change dysfunction and what we can do to help manage and, if possible, resolve the problem. Pelvic floor exercises, behavioral and cognitive techniques are all components of treatment. And really each of the 3 sessions that's available to these patients are individualized to really meet each person's specific concerns. Module 6 is our counseling services. Again, a really great opportunity for patients to take advantage of our counseling services. There's a variety of ways that our counselors can help patients. So when patients are newly diagnosed with prostate cancer, there's a whole host of emotions that they're going through in terms of fear, loss of control, and anger. Anxiety also obviously happens to be a big part of that as well. And talking to a counselor can really help them, give them some coping strategies. Also, when patients have had treatment and they've started to see that there's changes to their body, that also becomes a big issue for patients. So again, another opportunity to take advantage of our clinical counselors. They've got a wealth of experience behind them. And if it wasn't to do with any kind of emotional issues, our counselors can also help provide practical assistance. So, up in Prince George and Kelowna, there's lots of logistical issues in trying to get to appointments, and that can become very expensive. So our counselors can help with transportation issues or accommodation issues and other community resources that they may not be able to find, but counselors really have a great long list of different resources that they can give to our patients. This is the only module, just to point out, where the partner can actually take advantage of the clinic appointment without the patient. So we offer complimentary appointments for both patients and partners. They can come together, but if for some reason the spouse just wanted to come on their own, that's definitely possible in this module. So our last module is actually one of our newest modules. It's module 7 called Advanced Disease Management. This is an education session that's delivered by a medical oncologist or a nurse practitioner, which actually just recently changed our education session here. So this is an education session that really helps understand the disease characteristics and the natural history of metastatic prostate cancer. So it's also helping patients become with the different terminologies in terms of castration resistant and castration sensitive, and the different treatments that are available for metastatic prostate cancer patients. So a really good opportunity for patients to come in and take advantage of our program. And finally, this last slide just shows everybody where our program is available. We have 4 locations: Vancouver, Prince George, Victoria, and Kelowna. And I would really urge all of you, for any of you who have prostate cancer patients in your practice, to strongly recommend them to take advantage of this program. It doesn't cost anything, and we know that it really helps patients, whether they're just being newly diagnosed or post-treatment. Thank you.
Great. Thank you, Manita. Great overview of our program, and hopefully people will take advantage of these terrific modules. We're going to move on to Dr. Tamara Schenk here. Tamara is on our planning committee. I appreciate her input into choosing our speakers today. And Tamara, I was going to call you a senior medical oncologist. I hope you don't mind, but I'm a very senior urologist. Tamara has been at the Cancer Agency since 1994, and she's focused exclusively on breast oncology for the last 6 or 7 years. Many leadership positions, and she co-founded the After Breast Cancer Service, which we'll hear a little bit more about from Anita following. So Tamara, over to you.
Thank you so much, Larry. I realize this has been a very long morning and it's extending into the afternoon. So, but I believe that this talk that you're about to hear really brings together a lot of the pieces and sort of reinforces a lot of what you've heard. So hopefully it will maintain your attention. So caring for patients after initial treatment. These are my disclosures, and here are the mitigation aspects for my disclosures. So at the end of this talk, you will be able to perform an appropriate follow-up after the initial breast cancer treatment once that patient has been discharged into your care. You'll be able to recognize and assess the symptoms and signs of concern as opposed to symptoms and signs that are not of particular concern, and those can be hard to sort out. And you'll be able to address these issues more effectively. So first of all, just what the definition of a breast cancer survivor is. This is a person who has completed her initial treatment, which includes surgery, could include chemotherapy and radiation therapy. They have no evidence of disease, and the majority of them will be on adjuvant hormonal therapy, simply because 70% of breast cancers overall are ER positive. So what is the issue? So breast cancer remains the most diagnosed cancer for women in British Columbia. 28% of all cancers diagnosed in women are breast cancer. There will be about 4,000 new cases diagnosed in 2020. The 5-year survival rate is very high, and that means there's an increasing cohort of patients who have previously been treated for breast cancer and who are currently still on the hormonal therapy, which is usually 5 years and now can extend out to 10 years. So what you've heard this morning is really a lot of these aspects of the domains of well-being for survivors, and they're multiple. And actually, I was struck also by how overlapping they are for prostate cancer survivors, thinking about the exercise and nutrition stuff that we've heard about. But really, they cross all domains and they interact with each other. So it's really important to be aware of all these domains, the physical, the social, sexual, which we've heard about, psychological, and also spiritual realms of issues for survivors. I should have put vocational in here, but this is under social as well. And again, when you're working with people who are in the working age, like less than and equal to age 65, vocational issues come up as well. So what I'd like to talk about is really how to perform the appropriate follow-up after initial breast cancer, and exactly why we do that. So basically, we're a new potentially curable condition. And what are those conditions? Well, it could be a new primary in the contralateral breast, or it could be an ipsilateral recurrence in the breast or in the axilla. Detecting a metastasis is not felt to be a curable condition, and therefore you'll see we don't often, we do not recommend extensive scanning, etc. But I'll go into that in a little bit more detail. It's also to promote adherence to the adjuvant hormonal therapy. These therapies are life-saving. They definitely reduce the risk of recurrence significantly, but only if you take them. And if people stop taking them or drop out taking them, then that's an issue. And so promoting adherence is really important. And the other is anticipating and mitigating complications. And we've heard a lot about that this morning from Dr. Bebb, from Dr. Stratman, and from all our speakers. So who is meant to be doing this follow-up? Well, as you could see by the number of patients who are out there with previous breast cancer, this can't be done by a medical oncologist. And so we would like to empower the primary care providers as much as possible to be able to do this kind of follow-up. And there are studies that show that it was as effective as an approach by a specialist, having a family physician or primary care provider, nurse practitioner, do the follow-up in terms of timeliness of recurrence detection, overall survival, and quality of life. Okay. So what do we recommend? This looks fairly simple. History and physical examination every 6 months for 5 years. And then after that, a history and physical annually, as well as bilateral annual diagnostic mammography if they have both breasts. Certainly if a person has had mastectomy and reconstruction, then that's not an appropriate thing to do mammography. So in the intact breast, mammography. Those are the only 2 things that are recommended. Anything more than that, sorry, I'll go back. Many patients ask me, how about my tumor markers? How about scanning? How about this? And it is a bit confusing because not all cancers are the same. So you have someone with colon cancer, and there are recommendations to do CEA every several months for the first couple of years, and then every 6 months for the next 5 years to do intermittent scanning. And that's because if you find an oligometastatic site like a liver met in colon cancer, there are studies that show going after that metastases with surgical approaches and local approaches can change survival. But that is not the case in breast cancer. What you're looking for is detecting something new primary in the other breast, a local regional recurrence, which is a curable type of situation. And so we do not recommend in asymptomatic patients any other scans apart from this. However, when I discharge patients, I always have a disclaimer, a sentence that says, however, I would have a very low threshold for investigating any new symptoms and signs in a patient with a previous history of this disease. So asymptomatic patients with no clinical signs, this is what you do. If a person has any clinical signs, you're looking into it more. So what are you asking about in your history? Well, you're asking about any new breast changes, any new lumps or bumps, any skin changes. I'll stop right here because this can be a little bit confusing. A person who's had surgery, breast conserving surgery, and then let's say a re-excision, and then radiation, they can have changes to their breasts. In fact, that breast can be heavier, the skin could be thicker.
Please stand by while Tamara reconnects her camera and microphone. Audience, thank you. Thank you, Dr. Shankier. You had a little bit of a pause. You can continue.
Okay, thank you. I'm not quite sure what is causing these pauses because I'm sort of sitting in the same place the whole time. Anyway, all right. I was talking about the breast and skin changes. So you really want to know what the baseline of that the patient has, and any new changes over and above their baseline. But if you expect that the person will have totally bilateral, symmetrical, normal looking breasts after the surgery and radiation, that's not usually the case. You're asking them about their sleep. So insomnia can be a problem, and that can be from, depression or vasomotor symptoms. You're asking them about their mood. We've heard all about genitourinary and sexual symptoms associated with breast cancer. So this is something that some women are actually don't feel empowered to actually ask their practitioner. So I always, gently ask or have an opening where they could explore that further with some questions. And the big thing here is any new, unexplained, or persistent symptoms. A lot of times women say, oh, I still have pains. The pain, it comes and goes. It's fleeting. It lasts for seconds. It happens when I move. These things are not something that cancer does. What cancer does is it comes, it stays, and it gets worse over time. So if a person is being examined and for potential recurrent cancer, the new, unexplained, and persistent symptoms are the ones that we're worried about. Likewise, that would be the case for any late kind of side effects that develop. You're asking about medication adherence. When I'm writing these prescriptions, I'm seeing if they've actually been filled. If the person has only filled a prescription for 90 tabs in the past 180 days, I know that there's probably an issue going on there that they may or may not feel that they want to talk to you about. You're asking about any new medications, because certain medications can interact with the efficacy of the medications that they're on. So for example, the biggest example of that is the efficacy of tamoxifen can be diminished by some SSRIs. And I have sort of a list of those at the end of this, and a link that you can click on to look at that. You're also updating a family history. And so while the vast majority of cancers are sporadic, of breast cancers are sporadic, there are some women who have a familial or a genetic component to it. And that family history can present itself either before their diagnosis or after their diagnosis. And so there are certain criteria in BC that need to be had in the family history before we refer to the hereditary cancer program, and before that woman is eligible for genetic testing publicly funded. And so again, updating family history with any new diagnoses of breast, ovarian, endometrial, colon, pancreas, prostate cancer is important as we learn more and more about all the different genetic mutations that can potentially cause cancer, breast cancer to develop. And then we've heard a lot about lifestyle issues from Dr. Moyad this morning, and just hearing about the benefits of certain diets that cause weight loss and exercise. I'm not going to kind of reiterate that here. You're examining them. You're looking at their weight. You would even look at their height, because of course they can lose height if they're experiencing osteoporosis changes. You're examining their breast, the chest wall, looking for any cutaneous or subcutaneous palpable lesions. You're examining the reconstruction site, which can sometimes be an issue in terms of small palpable subcutaneous nodules. There is this aspect called fat necrosis that is seen a lot, and that can cause these subcutaneous nodules. I find it sometimes confusing, and occasionally I have to get the plastic surgeon involved in kind of helping me to distinguish. But a lot of times, if I'm worried about something palpable, I will send them for either an ultrasound or FNA. Axilla, lymph nodes of the neck, lymph nodes of the axilla, arm, looking at any swelling or changes in the ipsilateral arm that might be suggestive of either recurrence or the development of long-term toxicity. Hearts, lungs, spine, abdomen, and we heard a lot about gynecologic. So, like I said before, other tests or interventions are guided by symptoms or signs and you should have a low threshold for investigation, as well as the type of adjuvant endocrine therapy. So we saw from the slides before how adjuvant endocrine therapy can impact bone health and impact cardiovascular health. And those are things that a primary care practitioner is well placed to look after as well, probably much better placed than me as a medical oncologist. So that was what you need to sort of perform. And now I just want to focus in on some of the symptoms and signs of concern, and also how to address these issues more effectively. Both of those should be bolded. Sorry about that. So again, reiterate, when to be concerned: new, persistent, progressive, and especially if associated with pain or loss of function. Those are symptoms to certainly be worried about. And what to do: bring them in earlier for reassessment, send them for the appropriate investigations, and always a referral if concerned. Referral back to the oncologist or referral for other type of investigations. So I wanted to talk about a little bit about the lingering or late effects of local therapy. I think we're going to be hearing a lot more about that from Susan Deslip later on this afternoon. Actually, she's going to be talking about how to treat those things. But really, I think these are really underestimated. And as the medical oncologist, I'm the person who sees the person quite often. They're finished their surgical treatment, they're finished their radiation treatment, but the scarring, the myofascial tightness, the decreased range of motion in the shoulder, these are all longer term consequences of those local therapies. Postoperative pain, breast edema, arm lymphedema, these are all things that can happen and linger and remain kind of chronic. So it's important to address them, rule out other sinister causes. Certainly if they're associated with pain or loss of function, for sure you want to rule out a recurrence or brachial plexopathy. But really you need an integrated approach to pain management, including some sort of myofascial kind of technique, either through physiotherapy, through a practitioner of active release technique, massage, trigger point injection. There's many ways to get to the same outcome, but you just need to think about this and refer the patient appropriately. Whoopsie, we'll go back. Don't worry, I could press an arrow. Yes, okay. Again, some of our earlier speakers referred to this. The cancer-related fatigue or treatment-related fatigue is fatigue that's just out of proportion to other types of fatigue, and it doesn't usually get better with rest as usual fatigue does. And cancer-related cognitive impairment is also sort of enmeshed in this. These can be really distressing for people who are expecting to go back to their usual selves the minute their treatment finishes. In fact, at this point, I have a stamp that I have that says some patients require up to 12 months after the very last treatment is finished, and whether that's their radiation or their chemo, whichever, before they can even consider going back to work. Here in Canada, we're lucky that a lot of people are employed and they have some benefits. They have either long, sick leave or LTD. It's a problem for people who are self-employed or who are in the gig economy. It can take a long time to recover from these effects. The other group that I find is most challenging are really high functioning professionals who want to go back to their previous level of functioning in a very short period of time. Just convincing them that doing a part-time and a graduated return to work and taking your time pays a lot more dividends than rushing back, crashing and burning and going off on disability again. So again, for the fatigue, we're ruling out comorbidity, thyroid anemia, depression, sleep disorders. I mean, some people do have obstructive sleep apnea and undertreated pain. So those are the things to rule out. But then even ruling out all that, you're still left with a lot of people who just have fatigue and cognitive impairment, even once those are ruled out. A multidisciplinary approach. We're hearing this morning that exercise is medicine, and I can't emphasize that enough. I know Sarah Weller is going to talk about it later this afternoon, but super important. There are a lot of online or community resources. I'm not going to go into where to find them right now. Even cognitive rehabilitation is something, especially when a person is getting LTD through their employer, the employer is very motivated to send that person for some cognitive rehabilitation. Other neurological effects, we heard about chemotherapy-induced peripheral neuropathy, and that can linger. It shouldn't get worse over time. It either gets better or it stays the same. If something is getting worse, then there's usually another cause that you need to look into. You need to make sure diabetic, thyroid is okay, and remember carpal tunnel syndrome. It's a very common complication for women after breast cancer treatment. So that is just something that should be on your differential. I'm a little bit embarrassed by how small this little cardiac thing says, rule out CHF, but I'm very grateful to Dr. Stratman for having gone over it in a lot of detail. And then we heard about menopausal symptoms. So this could be, natural menopause, drug-induced, or drug-exacerbated. I find the women who I see who have the worst time are those who are on hormone replacement before their diagnosis. They have to go off the hormone replacement therapy, and then they have to go on some sort of aromatase inhibition. Those women often have the worst vasomotor symptoms. The menopausal consequences, Dr. Lipkowitz and Dr. Altus were talking about. I'm not going to reiterate them, but vasomotor instability is something that hasn't been talked about yet. So really there are other medications out there that can help with hot flashes. Dr. Moyad was also talking about acupuncture, which has been shown in some studies to be beneficial. These are small studies. But a lot of patients, I eventually prescribe venlafaxine for them. As you can see, there's a tremendous placebo effect, a 20% reduction in hot flashes from placebo. So any sort of really useful trial has to be kind of placebo controlled because you get a tremendous placebo effect. But you could see the lines that are lower down are ones that either use hormones, which are, contraindicated systemic hormones, or venlafaxine and gabapentin. So this is what I use. We've heard a lot about the vulvovaginal atrophy. Depression, anxiety. I mean, I was interested in the description of the 7 different modules and how counseling is such an important part of the prostate cancer supportive care for survivors, and likewise for patients with breast cancer. It's extremely important. Reduction of libido has already been discussed. Physical activity, really exercise as medicine. It improves almost everything. Body image, mood, physical condition, sleep, quality of life, increases sexuality and energy, maintains your bone health, your weight, and reduces fatigue, stress, and anxiety. So the more you can encourage that, the better, and the more we can facilitate that for our patients, the better. So just a couple of points on some specific medications that we prescribe. So with tamoxifen, which is a selective estrogen receptor modulator, the bothersome symptoms can be hot flashes, vaginal dryness, but in some cases it can be vaginal discharge. It's a mixed agonist and antagonist. It has different effects in different kind of tissues, and so it's kind of a little bit unpredictable that way. In terms of mood and weight gain, really in the prevention trial where we were using tamoxifen for primary prevention, there wasn't a huge difference between the mood and weight change of patients on placebo versus tamoxifen, but there are so many compounding other things that go on with breast cancer that often it's attributed to the hormonal therapy that we prescribe. Muscle cramps are something that people see, but the serious side effects are the irregular vaginal bleeding or the risk of venous thromboembolism. So patients who are premenopausal, who are prescribed tamoxifen, many of them still continue to menstruate. A lot of people don't know that. But people who are perimenopausal, it can be a little bit difficult to sort out what is irregular vaginal bleeding. And so that just needs to be, kept in mind with the patient. The bonus of tamoxifen in postmenopausal women is it improves bone health. And I've already told you about the caution with agents that are CYP2D6 cytochrome inhibitors like SSRIs, because they decrease the metabolism of tamoxifen to its active metabolites. And then the aromatase inhibitors, again, hot flashes and vaginal dryness and genitourinary issues. But one that you don't see very much with tamoxifen, but is the number one reason why most people, if they're non-adherent to these drugs, is the AI-associated musculoskeletal syndrome. They feel stiff in the morning, they can feel achy all over. Some people get it worse than others. It's unpredictable who is going to get it. It usually happens within the first 6 months of starting the treatment. And there's different methods by which we can try to manage it. They're all listed here. Analgesics, stopping for a few weeks, then resuming with another kind of AI to see if there's any difference, continuing with exercise. Acupuncture as well. And then there was a large study looking at duloxetine, but that did show some benefit. But when I offer that to women, they just don't want to take another pill to treat the side effects of a pill that they're already taking. And so there's very low uptake on that one. And then the heart health, lipids, and bone mineral density issues you've already heard about. Lifestyle. Diet, exercise, quitting smoking, reducing alcohol consumption, continuing with primary screening are very important, again, as the nurse practitioner and primary care practitioner and GPs know. And other issues that come up for a person that often require either counseling or some books that I can recommend. And again, I could send you those later in a link. I didn't list them here. So again, just the multiple well-being domains of well-being for survivors. They're complex, they're interrelated. And really what happens is some people do well and they can just be discharged, and other people have lingering symptoms that aren't best dealt with by a medical oncologist. And this is what we're going to now hear about from Anita Dotz, because this is why we set up the after breast cancer service for transitional care of these patients in between the medical oncologist and before they go back to the primary care provider. There you go.
Terrific. Great talk, Tamara. Thank you. So as you just mentioned, Anita Dotz is our next speaker. Anita is a nurse practitioner for the After Breast Cancer Service, and she's going to tell us about this transitional care program. So we'll switch over to Anita now. Thank you.
What I'm hoping to talk about is who's on our team, what are our goals of care, and what are some of what we look at in terms of a successful transition back to primary care. So the purpose of the program is really to see women, and we do have one male patient now as well, because men do also get breast cancer, and they need to be on endocrine therapy, and they have healthcare needs usually that are needing a further support. Part of our goal is also to work to support the medical oncologists so that they can see new patients earlier. As you can see from the numbers of breast cancer diagnosis in the province, they have a fairly significant workload. So that's part of our goal. And we're very much thinking about transition. What's going to be a successful transition back to primary care, and women feel supported and have a good relationship and understand that their ongoing usually annual surveillance is going to be done by their family physician. And we started as a brand new program in the 1st of May of this year. So one of the decisions we made right from the beginning, and I think it's been very helpful because we are a transition program, is that, all the patients that come to the After Breast Cancer program continue on with cancer service until they're ready to be discharged back to their primary care provider. As of May, we have myself, I work full-time. I have a partner, Melissa, who works 0.6. We have a wonderful RN that does a lot of work for us in terms of coordinating and symptom management. She works 0.6. And we have a clerk that basically manages the clinic for us and keeps us in line. And as I said before, we're located at BC Cancer, at Women's Health Center at BC Women's. Which has been very helpful. We saw our first patient on April the 17th. There was just me and a part-time clerk. That first year, we admitted a lot of patients to the program. In year 2, things kind of settled into a little less. I still was me, so we had to think about how many patients we could take on. And we've kind of transitioned to almost 500 patients now. And our patient population is hormone-positive breast cancer patients. We see both pre- and post-menopausal women. I would say our largest group is between the age of 40 and 65. We have a smaller cohort of women that are below 40. And we do have a fair number of women that are above the age of 65. We deliberately set the program up for our initial consultation is an hour. Our goal is really to sort of identify those unmet needs. And, it's an opportunity for women to tell their story as well. We follow the same kinds of guidelines that Dr. Shankier was talking about. We're looking at, breast cancer surveillance. So we're looking at for any new or persistent symptoms. We're really looking at that whole person. So their other comorbidities do matter because they can impact some of the symptom management that we may suggest. And we do focus on what are the endocrine therapy side effects they potentially are having and how can we mitigate them. So we kind of mix, between the breast cancer surveillance. We're not doing the primary care physician's job. We really are very clear about that we're a transitional service that really are focusing on how to address the unmet needs so women can continue to figure out what's new normal for them. We see a lot of side effects. I think in our initial intake, we talk a lot about sleep. We talk a lot about fatigue. We talk a lot about, the bowels, the bladder, diet, healthy eating. We never miss a conversation about mood. We think it's very important, and it's actually proved out in practice. Assessing for mood disorder and cognitive changes is a big deal with this population. And then we look at the specific, more common side effects that we're seeing with endocrine therapy. And we try to tailor those to the woman sitting in front of us. I think the most important thing that we've learned is that, in other practices, I might have prescribed a lot of medication. I tend to only prescribe endocrine therapy now because women don't want any more drugs. They're trying to move to new normal. And so the side effects in terms of other drugs are prohibitive often to having any success with them. I think one of the biggest things that I think surprised us is the fear of reoccurrence. We have the time, we kind of open that Pandora's box. And we're looking at how we support women. How do they wrestle that to the ground? We do a lot of support around healthy eating and exercise. And I think when we developed the program, one of the things we did is really look at who do we partner with, who are the community resources, and who do we need to partner with so that we can have resources that women can either partake in, participate in, so that they can move forward with their goals. I think one of the other important things is to determine, do they have stability around primary care? If they don't, how can we help them? and how do we really communicate effectively with their primary care providers. So we're doing transitional care, and we're supporting the primary care provider and the patient to keep connected. In the very beginning, we send a letter to the primary care physicians, which I think is really important. And at the end, when we're ready to transition them, I try really hard to have a conversation so that, the transition and the successful discharge is really what we're hoping. So, I think that one of the things that's been very, very surprising in some ways is we've had an opportunity, because we started with a pilot project and we did some research. And we asked our patients on many occasions, were we going in the right direction? And I think patient satisfaction with this program is actually quite high, to the point that we're busy people and we've added more time for other practitioners. We are very, very well supported with our virtual relationship with the medical oncologists. And, I think focusing on transition, and we transition people early when they don't need us. And I think our commitment is to look at different modalities to improve the care that we're providing, and addressing people's unmet needs as we need to. Okay, thank you.
Excellent program. And I think we're very lucky to have two very strong supportive care programs in our town here, with the PCSC and the ABC. Thank you very much, Anita. Hi, David.
Hello, Larry. How are you?
David is the Mossani Foundation Chair in Men's Health, Integrity, and Wellbeing. He's a professor in both departments of family practice and urologic sciences at UBC, world-renowned and for his work and research in transition, particularly in the military, and he's more recently with prostate cancer men as well as athletes and first responders. He's the co-founder of the Men's Initiative, TMI, and it's been my great pleasure to be working with David over the last number of years. So David will be presenting Living with Prostate Cancer, Loss, Grief, Depression, and Challenges to Identity. Thanks for being part of our program today, David.
And thank you, Larry, for the introduction, and thank you also to the organizing committee for inviting me to participate. And this is a particularly important topic to me. In previous research, one of the things I learned about healthcare providers is that we can be the cause of iatrogenic suffering. The way we talk to people can be actually more painful to them than their own disease experience. And so what's really important to me is that we begin to understand the experience of the patients that we see. And those people have actually been my best teachers, along with my children. And what I'm going to share with you today is based on many group projects that I've done or group work that I've done with men with prostate cancer, and they've taught me a lot about what it is to live with prostate cancer. So they will be your teachers today through the lessons that I've learned. And one of the features of all of this is that the most recent study that we did through the Prostate Cancer Center basically looked at, is there value in getting men together to speak about their experience? And just the experience itself of being together in 3 one-day features of this program reduced depression in the group that we worked with, and the improved depression lasted for up to a year. And so the work that we started off in Montreal and Halifax, and then came to Vancouver to basically look at what's the experience of men living with prostate cancer, and does coming together to talk about that actually make a difference to them? Because living with prostate cancer is basically an experience that is fundamentally male. However, it also affects their partners. And it affects them psychologically and emotionally as much as it may perhaps affect them physically, because they have to make adjustments to the diagnosis, to the treatment, the disease, and also then to living with the sequelae of the treatment. And that we can see from the survival rate at 93% is that men live with the cancer and with its treatment and sequelae for a long period of time. And that it's also happening in their lives when lives are already changing with regard to their strength, regard to sexual performance, and just the whole aging process. And that's already an adjustment and a transition for most men and women. And to add prostate cancer to that can only add to the challenge of making that transition. Because it often changes how men feel about themselves, because prostate cancer changes their bodies, their sense of self and function. And that for many men, the issues that they experience are very private, and for many of them unspeakable. So if through the course of the next while together, there's anything that you can pick up or learn with regard to making the unspeakable speakable as a clinician, you will be serving the men and their partners with regard to those men who have prostate cancer. As you can see, it's complex, and it has a wide range of sequelae that can certainly vary within the individual over time, and it certainly is also varied between individuals. So it's not one experience will be similar for everybody. And that these are some of the features that I'm just going to spend a bit of time on, because it's like they get hit below the belt with regard to loss of control, loss of sexual function, often as it once was, and loss of change of masculine identity, and loss of life. So these are very significant features that are important in terms of their transition from living without prostate cancer to living with cancer. So for example, the loss of control, as you can see here, and I'm just going to also insert a few stories here in terms of the experience of the men who've participated in the group that we do. And I remember early on, one of the participants talked about climacturia, and he was devastated by it because shortly after, or some period after his treatment, he was involved with a partner sexually, and he experienced climacturia. And he was very embarrassed by it, and he felt a lot of shame in terms of who he was. And he decided is that he would never again pursue anybody sexually. He would not be in a relationship sexually with anybody. And it resulted actually in him then experiencing a tremendous sense of loneliness and isolation. So it's important for men to have a space where they can begin to talk about this, and also to have the hope that features can be addressed in terms of their experience of living with sequelae. And then another one in terms of the loss of sexual function. And again, it varies greatly from one man to another, and it can vary greatly also within the experience of the individual. And in terms of the libido, I don't think as a clinician I fully understand or understood what no libido meant, or what it might be like to be on hormone therapy. And I remember one of the participants telling us that he, after hormone therapy, he really had zero drive whatsoever. He basically had to consciously tell himself to put his arm around his wife as they were sitting and watching television together. And he also then told us about the experience of his wife meeting him at the door without any clothes on and a glass of wine, with the hope that he would then be aroused and they would actually have some sexual intimacy. And he said it was devastating for me because I saw what she wanted. I saw that it's something that I would normally have also wanted to participate in, and there was nothing within me that could respond to her sexually. So it's really important for us to realize the significance of the experience that these men have or might have, and are we comfortable with these topics and inviting conversation about the topics in terms of the care that we provide for people. And it's also important to have an awareness that up to half of the men who participated in the study were already experiencing erectile dysfunction prior to having any knowledge or the experience of being treated for prostate cancer. So it can exacerbate or exaggerate what's already happening. But are men talking about this? And often men shy away from talking about intimate things, and men tend to talk about problems after the problems are solved. So it's important for us as clinicians to be aware of what the features of the experience might be. And then there's also a very significant change in terms of their sense of masculine identity. If you look at your identity, it comes from the core of your being as to how do you identify within yourself as to who you are, what makes you you. And what's important is that for many men, who we are physically is part of our identity. And how might that be affected after we've had treatment for prostate cancer? And you know, one of the most common features or concerns that men had is that when they got up in the morning and they're standing in front of the mirror, they didn't recognize the person that was standing there over time, partly because their penises were shorter. Some of them felt that they'd lost body hair and gained weight and gynecomastia. And they just said, and of course, gynecomastia isn't below the belt, but they just realized how significantly their lives had changed. And again, the value that they found in just being in a circle of men beginning to speak the truth. And many of them said after our first two together, we've just talked about things that we've never talked about with anybody else. So it's really important for us as clinicians, I know I've said this a few times, to be aware of the concerns that they might have, and to be perhaps be specific at times in terms of the questions that we might ask them or the topics that we might invite them to participate in. And then there's the whole essence of loss of life. But loss of life isn't just mortality. For many of the men, it's loss of life as it once was. And so that has to do with the transition. And it's not unlike swinging on a trapeze, so that you've been living prostate cancer free on this trapeze, and suddenly you realize that you got to catch another one because the next next swing is going to be very different from the one that you were on. And what does it take then to begin to live another life? And it's really important to realize that in this study, the life of the partner is as significant as the life of the patient. And it's often the men would tell us that they would only seek help because their partners, their wives, had told them to. So that the value of the prostate cancer supportive care group is that they very much invite the patient and the partner to participate. And we actually ran one group with the partners, and the women were very quick to say how much the illness that their husbands were experiencing was affecting their quality of life as well. And what's really important is to inquire of individuals and couples about how much are they talking with regard to intimacy. And if they weren't talking about intimacy and sexual intimacy prior to prostate cancer, it may get a whole lot more complicated once prostate cancer is part of the picture, part of their lives. And it might be very helpful to give individuals some very basic communication skills. And I'm going to give you an example of that shortly, because it's all about communication. And in the groups that we worked with, there were two concerns. One is men's challenge in accepting the changes in themselves and speaking to their partners about it. The other communication piece, which is quite different, is that they found it challenging. Many of them found it challenging to speak to their children, especially their adult sons, about their experience of prostate cancer. So it might be of value also to encourage people to men to have conversations with their partners, as well as with their children, sons and daughters. And really, again, to speak with one partner will likely improve the life of both of them. And that would be the purpose in certainly speaking to them individually, as well as with a couple. And here's one of the, I'm also going to just share with you some of the features of the program that we developed for men who are living with prostate cancer. And this is based on the work of Virginia Satir. And it's all about who we are in relationship with others. And you can see here that on the top of the iceberg is our behavior. And so often we behave in ways that we, with regard to messages that we might want other people to see with regard to our behavior. How we cope might actually be beneath the surface. And the two really important features of this slide are, first of all, the two lines that talk about feelings, and then feelings about feelings. That's might seem a bit complicated at first, but if any one of us feels shame, we may also feel embarrassment about the shame. If we feel hurt because our partners haven't recognized our experience, we may also be embarrassed about the hurt. We may feel fear of expressing anger. So it's really important to recognize that most or all of us have feelings about feelings. And the other piece that's important is to speak about expectations. In our relationships, whether it's as clinicians with patients or in our personal relationships, we have expectations of ourselves. We all have expectations of others, and we also have an awareness that others have expectations of us. And a lot of the men would talk about it's challenging for us to begin to address that expectations and desires that our partners might have with regard to our performance, our sexual performance, our level of energy can really affect how we relate and interact with them. So it's an important feature to understand the complexity of our behavior at home and in the relationships that we're in. And one of the common features, and we realized in terms of the relationship between partners, is that one of the common responses when the man or the husband partner, male partner, isn't able to perform or doesn't have the desire that he might have had prior to treatment, often the response of the partner is, well, it doesn't matter. And so the intent of the comment, it doesn't matter, is to diminish the hurt or the suffering that the man might be experiencing. However, we learned in our conversations with groups of men that it's actually a very hurtful response in terms of saying it's all right, it doesn't really matter that much. The men often felt misunderstood by that comment, meaning that they felt that their partners didn't fully appreciate how significant the loss of sexual performance, erection, might be to the male. And so it would result in withdrawal. So that it's really important in terms of all of our relationships that the intention I might have in saying something may not have the desired effect, even though I might believe that, for example, my intention would never be to hurt you in things that I say to you. doesn't mean that what I say won't be experienced by you as hurtful. And the complexity of this also pertains to the fact that all of who I am is encoded in how I speak and what I say. And all of who you are is used to decode what I say, so that in our relationships, we bring our past into the present. So there's often many reasons for the complexity of understanding or misunderstanding each other. And the other feature of who we are in relationship is a basic human need. And this is the premise of the program that we ran, is that the basic human need is to be seen, to be heard, and to be understood. And that works in both directions. If there's two people in a relationship, it certainly also works in teams. So if there's more than two, it means that that's true of all of us. And so what is it that we can do to make sure that we see, hear, and understand each other? And that's where a basic communication skill might be important. One is if I have a topic that I want to discuss with my partner, with my wife, it'd be wise for me to begin to appreciate my own feelings about having this conversation with her, and then also to begin to anticipate the feelings that she might have, and to be very aware of those features of the message, and the way I communicate would be part of the communication. And that if it's really something very significant, it may actually be of value to inform the person of the importance of the conversation. For example, I want to speak with you about something that's difficult for me to speak about. And especially if it's a topic that has been present for a long time, but unspoken. If it's an emotion that's been brewing for a long time, but it hasn't been addressed. And certainly if it's a topic that has never been talked about before, this might be a very valuable beginning. And even in terms of that bridge, to say, not only do I want to speak with you about something, not even quite sure about how to go about this, but I believe that there is something that I need to say, and I'd like to say it. And my intent isn't to hurt you by what I say. My intent is to be honest about it. And then to encourage the person who's speaking to make only I statements rather than you statements, because it's the way that vulnerability begins, is to begin to say, I don't know how to say what I need to say or want to say, and yet there is I believe that there's an elephant in the room. There is a topic that we're avoiding. I think there's something between us that's being lost. Whatever it might be, it's a way of enabling partners to begin to have difficult and challenging conversations with each other. And actually, one of the feedbacks we got about our program was the gratitude that the participants felt for that ABC method of communication. The program was such that we met once a week for 3 weeks. And by week 2, they'd say, we tried your communication skills approach, and it actually enabled us to have conversation that we hadn't had for a long time. And prostate cancer is a serious illness. While we know that many men who have prostate cancer will likely die of other causes, we also know that some men will think about suicide and others will attempt and complete suicide. So in the work we did, we used Joyner's method of identifying important features. One is belonging, second was burdensomeness, and third was comfort with lethality. And it's really important, and that's one of the values of the group. And the other measure we did was the value of just the group process and how did it contribute to your sense of well-being. And it improved the participants' sense of well-being for up to 3 months, and that's not surprising. After that, they lost that sense of belonging to that particular group. But how people belong to people who are important to them is really important and of value. And perhaps during this time of COVID, it may actually be more challenging as we're encouraged to stay home and make sure that our bubbles get smaller and smaller. The other important feature has to do with burdensomeness. If you hear anybody and your patients saying, my family would be better off without me in it, that's a big clue that they're beginning to feel like a burden. and that it may actually also be featuring their sense of belonging. And then comfort with lethality. As healthcare providers, we already have a higher than normal comfort with lethality. And what do we mean by this? It means that we listen very carefully. And I remember in one of the groups that we ran, we had a participant who'd really fought to be part of the group. And because we were still in the pilot study portion of the work we were doing, we were a little flexible in the inclusion criteria, because initially we wanted them to have lived with the diagnosis for a year. But he approached me and said, I don't want to wait. I've had this for 6 months. I'm desperate. I assure you, I've got a psychiatrist, a psychologist. I've got a church community. I play hockey. I've got lots of support everywhere. So if you're concerned at all about what will come of this, I'm well taken care of. Interestingly, he's also the very man who on the third day and at the end of our 3 days together, he said, I wanted to be part of this group, is that who I am as a man and who I am sexually is really important to me. And that after I had my diagnosis, I realized I began to entertain the idea of suicide. So I bought a motorcycle. And then what I did with my motorcycle, I started driving faster and faster. Then I went around corners faster and faster until I realized exactly where I might end my life on a rainy day and a winding road, and nobody would know that I had taken my own life. It was a very serious moment for us, and it's really important for us to be aware as clinicians that we need to ask questions about who these men are and how they might be experiencing themselves with regard to ideation, suicidal ideation in the prior week or even in the preceding year. And what do we need to know? And are we safe enough for them to be completely honest with regard to who they are? And another portion that's really important that the men talked about a lot, and if you look in the literature around masculinity, grief is not a popular emotion amongst men. Many of them experience it, but don't want to express it. And many men would say that I was taught how to be a man, and it meant I could be angry, but it meant I couldn't be sad. I couldn't shed tears. I couldn't express the emotion within myself. So it's important to be aware that grief is wanting more of what one will never get again. And that is actually what prompted the man who talked about the motorcycle. He realized that his sex life would never be the same as to what it was prior to the surgery and prior to the hormone therapy he was getting. And it was too much. He wanted to end his life because of it. So grief and sadness are an important part of the experience. And to be aware that grief can be experienced in or expressed in many ways. Through anger and rage, sadness, fatigue, lethargy, isolation is a really important one. And it could also be fear that life will never be good again, fear that life will never be the same again. And so
just a couple more minutes.
Here's their experiences, that they lots of emotions that they had. They became aware of their emotions and realized that what was deemed as depression may actually have been grief. And just in speaking with others, they began to realize and appreciate the complexity of what cancer, prostate cancer was, and that their experiences were unique, and yet they were also similar to that of the other participants. And isolation is such an important part of prostate cancer illness because men don't usually gather in groups, and that was one of the challenges we had in inviting them to participate and getting them to participate, because often men don't want to be talking about things such as this. And they appreciated being able to communicate with each other at a very deep and emotional level. So I encourage you to make this space safe enough for the men to speak the unspeakable and to include their partners and spouses in the process, because it does affect who they are in that relationship. And to make sure that you work at expressing empathy, that you understand their experience, their behavior, and their feelings. And that's why the Prostate Cancer Supportive Care Program is of value. It's not just individual, it has couples, as I said, it's educational, it provides opportunity for questions, it provides information, and it looks at all areas and components and experiences from the time of diagnosis to the experience of the treatment and sequelae, and also in terms of advanced disease. 2 slides. Men expressed a great need and a value in opening up and being authentic. And that one of them said that, I wish I'd known that 6.5 years later, I would feel as well as I've done, despite my experience of the illness. And then a very important quote, prostate cancer is not a death sentence, and that education, hope, and your support team can actually change you into a better person than you were before your diagnosis. So as much as you are part of the support team, I would invite you to declare that to the patients and then to work hard to make the unspeakable speakable. Thank you.
Patients who have been part of your focus groups, that it's totally invaluable. I mean, it's just amazing the changes and how important your work is. I'll remind the participants, if you have any questions, to please post them on the right side of the screen under Q&A, and we'll hopefully have some time at the end to address the questions. But we'll move on now to our next speaker. Susan DeSlip is a physiotherapist originally from Glasgow, which I guess you'll recognize in a moment. She's worked through UBC School of Rehab Sciences as a lecturer, has taught physiotherapy postgraduate clinical courses throughout Canada and internationally. Her clinic is called Go Physiotherapy and Sports Wellness Center, committed to developing clinical expertise and providing highest standards in physio-oncology care. So she's going to talk to us about some solutions for upper body shoulder pain conditions following mastectomy. Thank you, Susan.
Yes, so my topic is the physiotherapy solutions for upper body shoulder pain conditions following mastectomy. This is a common problem for a lot of women that come into our clinic. They're often so appreciative of the incredible cancer care that they receive and the standard of care that they receive, and that they have, hopefully a really good outcome for their future in terms of medical care. But at the same time, they're coming in with lots of pain and dysfunction and problems that they're struggling to find solutions for. So one of the objectives today is to sort of discuss how surgery and radiation treatment for early breast cancer may alter the mechanics of shoulder function, thereby setting patients up for sort of mechanical dysfunction, postural problems, limited range, and persistent pain, as well as soft tissue complications that arise following surgery and adjuvant therapy. They're often quite difficult to differentiate and quite difficult to diagnose. And understanding how physiotherapy can facilitate the early recovery and rehab. First of all, a little summary of how the mechanics of the shoulder work. There is the glenohumeral joint, which is a ball and shallow socket, cup socket articulation, enabling us to have such a large range of motion, but at the same time, it renders the shoulder inherently vulnerable to changes in the soft tissue tensions that affect that joint. So anything that makes that ball ride up and around in its socket potentially can cause later problems of tendonitis and tendinopathy and subacromial impingement problems. And then at the thoracic spine, there's the bucket handle movement of the rib cage with articulation at the sternum and at the vertebrae and the overlying muscles affecting that, as well as the scapular movement around the thoracic wall. So the post-surgical scarring and radiation-induced fibrosis are complications that can result in muscle imbalances and changes in the tissue tension, reducing the tissue elasticity, and then that can set patients up for faulty movement patterns, and as I mentioned, potential tendinopathy, which over time can then cause contracture in the underlying capsule and frozen shoulders, and these can really cause significant longer-term pain. So looking first at radiation-induced fibrosis, I don't want to go into the huge pathophysiology of it, but basically there's DNA damage, there's a cascade of inflammation, TGF-betas are scar former, reactive oxygen species is released with tissue and vessel damage, there's poor vascularity, excuse me, there's the proliferation of myofibroblasts and the extracellular matrix. The irradiated tissue is less flexible and it's harder, and therefore the underlying muscles tend to shorten and atrophy and don't contract and relax quite as efficiently as they did prior to this treatment. So the net result can be that it's a complication for having poorer outcomes following a surgical reconstruction. If there's contracture of the pectoralis major muscle, which can happen with surgery as well as with radiation fibrosis, then you can get asymmetry of the implant and just a poorer, less satisfactory aesthetic result. There can be chronic impairment as well. And in physiotherapy, we really want to address these kinds of increased tightness if we can by using very mild warmth. We don't want to heat the tissue when there could be sensory impairment, but just a mild warmth in an attempt to sort of soften the tissues for a very brief period. And then we use manual therapy and soft tissue techniques to try to release the adhesions and the tethering and to try and improve the elasticity. And that can be very effective and really give people a lot of relief in their discomfort. Post-mastectomy neuropathic pain syndrome can be something that's quite difficult to diagnose because there is pain associated with the normal post-surgical healing. There can be pain related to previous injuries from tendinopathies in the past. But the post-mastectomy neuropathic pain tends to be more recognized by sensory nerve irritation. So the patient will describe burning, hypersensitivity, intolerance to light touch, exquisite tenderness, allodynia, dysesthesias, and those types of symptoms. And it'll be really persistent. It won't necessarily drastically change with their positions or their movement. They may find that they really can't tolerate touching the tissues, and they don't particularly want us to either. But it does actually respond well to very progressive gentle manual therapy. So it's related to the extent of the cancer invasion. So it tends to be worse with more invasive cancer types. The type of surgery, it does not seem to be directly related to intercostal brachial nerve palsies or damage due to surgery. And it can be related to the adjuvant radiotherapy and chemotherapy as well. It is really quite common, so it's something that we all probably should be on the lookout for. Up to 60% of women treated for breast cancer do experience this kind of pain, and up to 80% experience sensory disturbances a few years later, so really persistent. And it's something that isn't really terribly well resolved with stretching alone. It really needs a little bit more than that in terms of manual therapy and assistance from a physiotherapist. Most commonly affected is the axilla, 66% of the time, and the arm, followed by the breast and the side of the body. So there's an increased risk with younger patients. Some of these incidences are not entirely known why. We do need more research, but it may be because of a higher tumor grade in younger patients potentially, or maybe they're more aggressively getting back to exercise, or they may have, heightened sensitivity compared to an older patient. It can be increased following radiotherapy, axillary lymph node dissection, greater when tumors potentially are located close to the chest wall or the nipple. And interestingly, it does seem to be associated with a greater degree of pain pre-op, and that could be pain that's unrelated to the breast cancer. So it could be a fibromyalgia, neck pain, back pain that was pre-existing that seems to preempt this. And then post-operative pain, the greater the acuity of the post-operative pain does seem to give us a warning sign that this patient may be more vulnerable to having more persistent neuropathic pain. And again, it can be associated with body dysmorphia, where that patient may have difficulty even looking at themselves in the mirror, even months later. And we sometimes have to really assist them with that. And it can result again in faulty movement patterns, altered breathing patterns. And as I said, it doesn't seem to be resolved with stretching alone. So again, the manual therapy techniques, posture correction, correcting their biomechanics, breathing patterns. It's really important that these things are properly diagnosed in order to be managed correctly. Other complications seen in the physiotherapy clinical setting, aromatase inhibitor-induced arthralgia is certainly quite a common problem that we deal with. It can lead or be somewhat related to muscle tenosynovitis, most commonly at the base of the thumb, the wrists, the hands and the feet. Adhesive capsulitis is unfortunately quite a common condition. It may be partly related to the aromatase inhibitor arthralgia. It may be related to a subacromial tendon impingement that can happen because of the altered tensions and the altered biomechanics of the ball and cup socket and other areas of the shoulder girdle. It can really also occur because of imbalances, because of having a tissue expander in, the tissues not having adapted to the new implant and so on. Most commonly identified, if you want to pick this up, it's going to be most often identified by a limited outward rotation with the arm either at the side or up in abduction, or difficulty putting the arm behind the back, because most of the other conditions that we see will not result in that limitation of rotation. So that would be a clue that this patient may have this, and it can be persistent, it can be difficult to treat, but certainly they seem to do much better once we can get them in, especially if we can get them in early and get treating the predisposing conditions. The breast reconstruction with tissue expander can sometimes cause difficulty when that expander is fully inflated. There can be tissue irritation where the edges of the expander dig into the surrounding soft tissues, or exerts a back pressure on the ribs, causing costal joint pain, or even mid pain and so on. Following the Dieppe and tram flaps, we sometimes see painful adhesions, restricted movement because of scar tissue around the umbilicus and in the abdomen. That can make it difficult for patients to regain their normal posture and their ability to extend their lumbar spine. And that can even cause, further back pain, especially if they're predisposed to that. And excuse me, commonly an impairment of core muscle recruitment. And that's really, really important that is addressed properly and paced properly. Otherwise, it can affect the stability of the spine and the ability to load the body with more resistive exercise later on. And chemotherapy-induced peripheral neuropathy is another common disorder where patients experience sensory motor alterations, postural instability. They may find that they're having difficulty with their balance, that they're stubbing their toe, they're tending to trip and fall, and that can have quite traumatic implications as well. And seromas and hematomas are quite commonly seen in the breast and the axilla. Typically, what we want to do with those is get compression on them as early as possible. Sometimes a gentle massage, depending on the stage of healing. But these are all conditions that we commonly have to address in a number of ways. So looking at cording, what we recognize is that the lymphatic arm collectors are caught up within the surgical field for sentinel lymph node biopsy in up to 40% of the time, and up to 81% of the time for axillary lymph node dissection. So the current thinking is that the high protein content from the lymphatic fluid then leaks out from the site of vessel disruption, and it forms little microscopic lymphoceles. So that lymphatic fluid can be coming in contact with the hemoglobin, and the tissue injury releases the clotting factor X and necrotic cells, and that can then cause the hypercoagulability of the lymph, and that then adheres to the surrounding tissues, causing a fibrotic tethering. So the concern here is that we don't really want aggressive stretching happening when that area is tethered, because that's going to potentially cause little micro tears and an inflammatory cascade and just superimpose on the fibrotic response. So it is considered, however, to just be an excessive but otherwise normal lymphatic phenomenon related to the body's natural healing process. So it's just more that it needs to be managed carefully so that we can avoid aggravation and further traumatic injury. Mondor's cords are interesting in that they are not synonymous with axillary web syndrome. And this can make differential diagnosis quite difficult, because Mondor's cords are considered to be much more likely to be venous inframammary thrombophlebitis that is seen inferior to the inframammary fold, just below the breast. Now, one of the differences is they do feel a bit different. The Mondor's cords tend to come vertically down. They may come directly down or a little bit more laterally. They can be just a centimeter or two in length, or they can extend all the way down to the inguinal canal. And they tend to be identified by raising the arm up above the head. And as that implant or expander has difficulty gliding upwards, and this little phlebitis is sort of adhered there, you'll see it visibly under the skin. But it is really important to note that with both axillary web syndrome and with Mondor's cords, they are often visible, but they may not always be visible. So it is important when examining to actually palpate, try to feel for these things when you ask the patient to raise their arm above their head. So the incidence, according to Alan Goldman's paper in 2018, is thought to be up to 1% of patients that experience this. But I suspect, and others suspect, that it may be much more common, given that it isn't always visible. But it can be a source of discomfort for patients, and the management and treatment of it is different. So whether it's inframammary or whether it is a forearm phlebitic cording, these conditions, the venous conditions, are less tolerant to stretching. So we don't want to be stretching those, and certainly not stretching them aggressively. Otherwise, that could really exacerbate the condition. So it's better that these are treated with potentially very light, gentle, soft tissue release and massage techniques, but also a warm compress seems to work well. They do tend to resolve quite well and within not too long a space of time, but they really ought to be treated to make sure that they aren't persistent. Another condition is the capsular contraction of the implant that we quite commonly see, again, because of the shortening of the pectoralis major, particularly following radiation therapy. There can be also an autoimmune response that is occurring as well, causing that implant to really be glued down to the rib cage. And sometimes it just can't glide at all. It's just really stuck down there. It's aesthetically not appealing. It's uncomfortable for the patient. Often that implant does have to be surgically replaced, but in many cases, we can absolutely work to try to release those adhesions, and patients often feel significantly better after that. But when it is encapsulated, it can exert a back pressure on the ribs, causing costal pain, upper back pain, and sometimes even rib subluxation in some cases, either anteriorly or posteriorly. So again, we tend to need to do progressively more vigorous techniques to try to release those adhesions. All right, and the axillary web syndrome is something that I think we've all seen. It is difficult to pick up on MRI or ultrasound. It seems to have a wide-ranging rate of occurrence, I think, because many of the studies have different methodology, and it will depend on the type of surgery, with the number of ipsilateral lymph node dissection, whether one or more nodes, as well as the length of follow-up in that particular paper. But it is recognized to be common. Greater incidence in women that have a lower body mass index, following axillary lymph node dissection, and proportionate to the number of lymph nodes that are removed. Common in women who are younger, and who exercise more frequently, and again, may be attributed to too vigorous or enthusiastic exercise, potentially a little too early when the tissues are just not quite ready for that. Also related to adjuvant chemotherapy and radiation therapy, for some of the reasons already expressed. The onset can be anywhere between 2 and 8 weeks in approximately 88% of patients, according to Linda Kohler. However, a later incidence is not uncommon, cited as being in up to 12% of patients. And certainly we, as clinicians, have often seen this condition resolve only to pop up again many months or even years later. So it can be recurring. It is often identified visually, as in the photo. It can most commonly be seen by abducting and extending the arm in elevation with the elbow and wrist fully extended. And you will then see this bowstring sign. Again, it's not always visible, particularly if it is not so long and extended to the periphery as the photo shows. It may only be an inch or two long, and it may be fairly deep within the axilla. So again, it can be a source of significant discomfort for that patient. So we do want to palpate as well as observe to look for it. It may be triggered by jerking, pulling, overreach, overload activity, anything where the excessive forces being applied to those tissues exceed what the tissues are ready for. And then that sets up an inflammatory cascade and additional layering of fibrosis. So we will really want to avoid that happening on a repeated basis. In severe cases, it can be very severe where patients can't even raise their arm above the horizontal, and that may even delay the start of radiotherapy. It typically does not spontaneously resolve. It's not always self-limiting. It can persist for years and continue to cause distress and anxiety and discomfort to the patient. So again, the sooner that we can address these conditions, the better. We use a number of soft tissue mobilizations and release techniques. We don't want to aggressively try to break the cord. That is much more likely to be too traumatic and set off an inflammatory cascade. So we do want to be applying our techniques carefully, along with appropriate stretching. So lymphedema is often causes a lot of confusion for people. Basically, it should be diagnosed as soon as there are clinical signs of vessel congestion. It's really indicated by insufficient resorption of the protein-rich extracellular fluid by the impaired lymphatic system following axillary lymph node dissection. So that congestion that happens following that disruption then causes that lymphatic vessel to dilate, and the dilation causes the vessel valves to be ineffective at doing their job, and so you see a retrograde flow into the peripheral section of the vessel. So the areas most affected are the ipsilateral to the axillary lymph node dissection. The arm and the hand are probably most commonly affected, but we do often see the lateral thorax, the trunk, and the breast as well. And breast lymphedema is noteworthy because we can't really affect that with the muscle pump that we can by doing resistive exercise with the upper limb. So we have to rely on very gentle manual lymph drainage techniques and compression to try to treat that. It's can be present at any point following surgery and treatment. The risk does not reduce with each month that goes by. It really can occur decades later. And 1 in 5 survivors are generally found to experience breast cancer-related lymphedema. The risk can be increased with infection or trauma. So a lot of what we do in physiotherapy at the beginning is education, breathing, diaphragmatic breathing to improve lymphatic flow, skin care to keep the skin moisturized, avoid getting scratches on that affected side so that we reduce the risk of infection, and making sure that that patient knows to seek assistance from their doctor if they do feel that something isn't healing properly. Higher body mass index, it's actually the opposite of the axillary web syndrome. It isn't really known why, whether it's with more adipose tissue, it simply isn't visualized as easily, or whether it has to do with the greater adipose tissue causing reduced adherence. It isn't known at this time. It is proportionate to the greater number of axillary lymph nodes dissected and physical activity. So we know that being active and doing resistive exercise, particularly with a compression sleeve or compression garment being worn, is helpful. Stages of lymphedema, we really want to catch people early on. So stage 0, when they may come into the clinic with a feeling of their arm being fluidy or being heavy, but still there may be at that point no visible signs or measurable difference in terms of swelling. And we would still get them at that point, we'd educate them to prevent lymphedema. We'd get their arm elevated doing a muscle pump type activity. We'd probably get them fitted with a custom fitted compression garment. And then stage 1 is where there's now visible and measurable swelling, but it's intermittent. It's resolvable. When they do these sort of methodologies, swelling goes down, but it may return. And then stage 2 is when it's hard to reduce that swelling. And there are now signs of that fluid becoming harder or becoming fibrotic. And that's then much harder to reduce that swelling. So we have to then look at more tight-knit, stretch-type bandaging to try and manual lymphatic drainage techniques to try to get that swelling down, and then ultimately looking at managing it. So this slide is just giving a summary of what I've just discussed, just the diaphragmatic breathing being important, patient education, skincare early on to try and prevent patients getting to the stage of stage 2 and stage 3. That's the key. So the earlier that we can educate people and assist them in the prevention, the better it is for all of our patients, because there is a significant risk to many of our patients. A home care program, once that lymphedema is successfully reduced, we want to teach the patient how to do their own manual lymph drainage, how to manage it themselves, making sure their compression garments are working for them. They can wear a particular type in the daytime and a different type at nighttime. And to do the muscle pump resistive type exercise in combination with wearing the sleeve. So, yes, and so I have uploaded this next section because I don't want to go through it piece by piece.
Susan, just a couple more minutes, if maybe you can wind it up.
Absolutely. So by all means, feel free to download this section. It is in the documents attached with this, but basically we just want to carefully progress their exercise. So the ACSM roundtable did emphasize that individuals with complications due to cancer-related treatments or multiple comorbidities should obtain a pre-exercise physio evaluation for the musculoskeletal deficiency signs and symptoms. So just really important that a physiotherapist helps them to pace their exercise to make sure that they get back to the activities that they want to be doing safely and without adverse events, and get back to work and life is normal. And many patients are unaware that there are physio solutions available and where to access that help. Thank you so much for listening.
The presentation emphasizes the need for a multidisciplinary approach to the oncology issues that we all deal with, the patients' problems that we deal with on a daily basis. So thank you for that. And again, you can see her website there, gophysiotherapy.ca. And we'll move ahead now to another very interesting and important talk by Dr. Pippa Hawley. I've heard Dr. Hawley present this, and it's truly a fantastic talk. Basically, Dr. Hawley trained in New Zealand and has been at the UBC Division of Palliative Care and a clinical professor in the Department of Medicine at UBC. She's going to speak to us on medical cannabis and cannabinoids for cancer patients. Dr. Hawley.
My name is Pippa Hawley and I work at BC Cancer. I started the Pain and Symptom Management Palliative Care Program back in 1997, a long time back, that ages me a bit. And I also work as the head of the Division of Palliative Care for UBC. And what I've been asked to speak about again this year is medical cannabis and cancer. And this is a topic that comes up very frequently with people with many kinds of cancer, not specifically breast or prostate. So nothing I'm going to be talking about is exclusive to those particular tumor groups. And I know we're a little bit after time, so I'm going to try and whip through things fairly quickly. I would like to say that in order to preempt some questions, I need to give you some basic sort of physiology, just so that people understand the terminology when it comes to accessing cannabis for medical purposes. But I'm going to not go into great detail. I found in general that this audience is often highly informed, and if I don't include any of the more complicated stuff, then it just comes up in the questions, and people feel they haven't been given anything new. So hopefully, I'll get the balance about right for the majority of you. So I'm not aware of any conflicts of interest. I am hoping to do a study on medical cannabis, which is going to be using product that's donated by a licensed producer. But I don't stand to benefit in any way financially from that. And sadly, I didn't invest in any cannabis stocks and shares back when there was interest in that. I don't retain any speaker honoraria from the cannabis industry or other commercial entities. So as I say, just a very brief discussion of the medical issues with medical cannabis since we got legalized, which was October of 2018 now for recreational use. And just to make sure people are aware that my perspective is an internist, I'm not a family doctor and I'm not an oncologist. And the patients that I mostly see are either living with cancer or survivorships, in the survivorship state with cancer or following cancer. This first diagram here is really just a kind of cartoon of the brain to show that there are more cannabinoid receptors in the brain than any other type of neurotransmitter. So clearly cannabinoid receptors are very important in all of us. So as you are sitting here, hopefully enjoying the digestion of your lunch and hopefully not falling asleep too quickly, just reflect on the fact that you have cannabinoid molecules, all of you, running through your veins, saturating your nervous systems and keeping you alive, helping you to live well with the pleasures in life, particularly like sleep, exercise, mood, sexual drive. There's a whole load of things that without cannabinoids, our lives would be so much more miserable. And you can see on the diagram there that part of the brain, this bit down the middle called the brainstem, that kind of looks like the trunk of the green tree there. This is the part of the brain that controls respiration. And you can see that out of the brain, this brainstem is the area that has the least density of cannabinoid receptors, which is one of the reasons why it's so safe. For opioids like morphine, hydromorphone, oxycodone, the opioid receptors are fairly densely populated in the brainstem. And so you can accidentally stop breathing if you have an overdose of the opioid molecules. Whereas with cannabinoids, if you had an overdose of a cannabinoid, you'd feel kind of weird and it wouldn't be a whole lot of fun, but you wouldn't actually die from it. You would be still breathing and you would recover and be back to normal shortly afterwards. Thanks, Tamara, for letting me know that you can hear me. As I say, it sounds like I've got a lawnmower going in the background here. Anyway, I will plow on. So there are two different kinds of cannabinoid receptors. The ones that I was just mentioning are the CB1 receptors in the nervous system, but there are these other receptors called CB2 receptors that are mainly in the immune system. And they're particularly densely populated in the glial cells in our brains. And the glial cells are the sort of glue and the framework that holds our brains in place, because it's kind of jelly-like, and if it didn't have the glial cells, it would all just kind of puddle at the bottom of your skull. So the glial cells are what holds your brain in this very complex three-dimensional structure, and the glial cells have particularly high density of cannabinoid receptors. These have powerful anti-inflammatory effects when stimulated. So there's lots of interest in use of cannabinoids in a variety of inflammatory states involving the brain. There are also other parts of the body, like the bones, they're infected. And because the CB2 receptors are so ubiquitous throughout our bodies, you have to be very careful when you start trying to manipulate them, because you can inadvertently cause problems in other systems to the one that you're targeting. So that sort of thing about unintended consequences, that's actually a big deal with cannabis. And that's why it's so important to understand its role carefully in cancer care, because you could, even though you make somebody better in one respect, you might inadvertently cause a problem in another system. So we're very much at the early stages of exploration of this, particularly as we haven't had the products that we need to do the research until very recently. So just be a little bit aware that that this is very complicated medicine and you have to be careful. Another thing that makes things difficult to study and to advise patients about is that the receptor activity and actually the number of receptors as well changes when you're sick as compared with when you're well. So it's not like a system where you can test healthy volunteers and then assume that what happens in them occurs in people who are unwell. And in fact, you might have very different effects in those different groups. And studying people who are sick is much, much harder to start off with than studying people who are well. So the way that this CB2 receptor activity changes is part of our body's natural adaptation to need. It's one of the reasons why the human race has been so successful in taking over the planet. As you can see from the this picture here, the use of cannabis for medical purposes and recreational purposes has been around for not just centuries but millennia, it's actually not the leaves that are the part of the plant which is so. Sorry, this noise is really putting me off here. I don't know how I can turn it off. It's not the leaves, even though you see in the advertising for cannabis, normally it's that picture of the flower. In fact, it's actually the leaves. It's actually the flowers that produce the high density of cannabinoids. And the flowers have these little long tubular things called pistils, which have little hairs on them. And if you look closely at this picture, you can see that the little hairs actually have little beads of oil on them. And it's that oil that's on these little filaments in the flowers that has the very high density of the cannabinoids. And the flowers have different amounts and different relative amounts of different cannabinoids at different times of day and different phases of the growth cycle. So from any one plant, you can actually get quite different products depending on when and what time of day you actually harvest them. So it's not just about the strain. There's other things that you can have one strain and still get many different products from it. So the horticulture around medical cannabis is also quite complicated, and that's one reason why people growing it on their balconies or in their back gardens is probably not a good idea, because they're not really going to be able to have any control or knowledge of what they're actually getting from their plants. So we talked a little bit about the two different kinds of receptors, but there's another kind of tandem with medical cannabis, which you need to know in order to be able to actually buy it and decide what to take, and that's THC and CBD. These are the two major cannabinoid molecules that medical cannabis produces, and though there are about 400 odd other chemicals, it seems that the THC and the CBD are responsible for the vast majority of their effects. The THC is responsible for the euphoria that people get when they use it for recreational purposes, but also seems to be responsible for the antiemetic effect and analgesic effect of cannabis. CBD seems to have more of the anti-inflammatory effect. It does affect the CB2 receptors as well as the CB1 receptors, but the way that CBD seems to be important is that it actually modulates how THC interacts with the receptor. So you can have THC glomming onto a receptor alone doing something, and CBD has a different one glomming onto a receptor and doing something else. But when you have the two together, they actually work completely differently. So it's actually quite complicated how the two work together. And it's not just 1 + 1 makes 2, it's more like 1 + 1 makes 5. So if you are thinking of trying medical cannabis, it's important that you start off with at least the same amount of CBD as THC in a product. So a 1-to-1 ratio would be what you would be going for at the beginning. If you are particularly concerned about the psychological effects of the THC, you might even want to go lower with the THC and maybe make like it 1-to-4 or something like that. But don't go with a almost purely CBD, like a 20-to-1 CBD to THC. Particularly if you're treating symptoms, because that probably won't work because you actually need a bit of THC. Okay, so just going back a little bit to us staying alive because of our cannabinoids, there's this concept of endocannabinoid tone, which is fairly recently been described, but I think there is good evidence for it. And this is the idea that every individual person has a state of interaction between the CB1 and the CB2 receptors and the two major cannabinoid molecules that we have in our bodies. And this seems to be genetically determined to an extent, and then there are other conditions or triggers which might affect it, kind of like the genes versus environment theory. This really does seem to be an important way for us to think about cannabinoid function. For example, some people can be born with a predisposition for addiction or for depression or anxiety, and these have been well studied in twins. But you can have two twins both with the same genetic predisposition, and one of them can be adopted to one family and have a very pleasant childhood and grow up being completely normal, and the other one may have been in and out of foster homes and end up with severe psychiatric problems. So there's clearly an element of environment, but there's also this genetic potential thing as well. And there are some cannabinoid deficient states which have been clearly recognized. Again, it's not all genetics, there's environmental things as well. But this sort of complex of irritable bowel syndrome, fibromyalgia, chronic fatigue seems to be related to dysfunction of our endocannabinoid system, which opens up the possibility that by manipulating it, by taking cannabinoids, we may be able to fix that or at least improve it. Conversely, there are some situations where it seems like the cannabinoid system is hyper functioning, and conditions like schizophrenia, morbid obesity, attention deficit hyperactivity disorder are also susceptible to manipulation of the system to try to improve them. And CBD seems to be particularly important in this tone. The THC seems to be quite useful for short-lived effects, but CBD seems to have much more of a durable effect. So depending on what you're wanting from your medical cannabis, that would also determine your choice of different products. Seems to be some slides it does this on. I don't know why. So I will go quickly on the ones that buzz. So the access to cannabis and cannabinoids as of recreational legalization, you really have 5 different choices, and I've listed them up there. The legal prescribed products that I've mentioned here, nabilone and nabiximols, are the sort of things that your doctor could just write a prescription for. You take it to the drugstore and then you bring it home just like you would an antibiotic or an antihypertensive medication. The alternative is the legal plant-based medical products where you have to go through the mail, though that may change soon, but you have to go through the mail to a Health Canada approved licensed producer. And these are factories that are all over Canada now, and they're licensed, they're inspected. All the products are guaranteed that what you see on the label, it's what's in the product, and they're guaranteed free of pesticides and molds. Those are the ones that I put in green. The ones below, I don't recommend, but they are unfortunately ones that are still very commonly used. So these are the conditions with claims for benefit. They're numbered here. They're colored here. So the red ones are the ones that Health Canada have approved. So there are clinical trials that show that this is beneficial for them. Muscle spasm, actually in multiple sclerosis as well as ALS, but it's more in multiple sclerosis than ALS. Spinal cord injury, cancer pain and cancer survivorship pain, particularly neuropathic pain, and wasting in AIDS. And you can see in green here, there's a whole host of other conditions where there is really quite strong evidence, but not quite as far as enough to convince Health Canada to actually approve it. And then there are some where I've written them in black here, or where there's a lot of anecdotal reporting and some small trials, but that not even close to the level that Health Canada would need for actually approving it for general recommendation. But you can see it is actually spreading through many different conditions. The problem with looking at a lot of the reviews of these medications is that they often only use either THC alone or a synthetic equivalent. And nabilone is actually just a synthetic THC. It doesn't have any CBD in it at all. So it's designed to be the most poorly tolerated. The balance of cannabinoids in a lot of the products, particularly in the early days of research, were not reported. So one can assume that they had very little CBD, and in fact, some of them may have had very little THC as well. A lot of the studies tried to use the traditional randomized controlled clinical trial paradigm where you start with a small dose and build up. And they didn't incorporate the fact that everybody's a little bit different. So there wasn't this ability to individually titrate the doses. So consequently, a lot of people would be either given too little or too much. So there'd be a higher proportion of patients would report adverse effects or lack of benefit, as compared with studies where people could adjust their dosing to make it just right for them. The other thing is that they use products that are effectively unavailable now. There was actually more research done with a product called Marinol, which is no longer even available in Canada to purchase. And the Sativex, which is the one that I think is the best product, and that it has a 1-to-1 ratio of THC to CBD, and it's plant-derived. It is $700 for a pack of 3 ampoules. And one of the ampoules, which is a little spray that goes on the inside of the cheek, might not even last you a month. So it's basically, though it's an excellent product, it's priced itself completely out of the market. The other problem is that a lot of the studies were using standardized cigarettes, and we actually don't recommend inhalation at all because of the products of combustion. They're not good for you, all the tars, and inhaling any kind of smoke, whether it's got nicotine or cannabinoids, is not a good idea. So it's actually very difficult to extrapolate from all these old studies as to how we should be recommending people use modern cannabinoids. And we recommend that people use oils now rather than dry plant product. And we get them to have at least 1-to-1 CBD to THC. But there's actually been no clinical trials using those specific products, which are extrapolating from what we know from the Sativex studies. So there is a lot of challenge in doing cannabinoid research, and I've been trying to get this study going at BC Cancer for years now, and we're actually really very close now. We hopefully will be able to start before Christmas. But there are a number of reasons, as I've listed up there on the slide, why it can be very difficult to do this. And I think the way that people think about it has to change, because when you're using a naturally derived plant product, there are limitations on standardization that you can have of products, which are not really clinically relevant. Like as long as it's close enough, it doesn't really matter if it's like 1.23% THC to CBD versus 1.25. And Health Canada gets really tied up in these minutiae, and it takes months, if not years, of back and forth trying to get approvals for one particular product. But every batch has an expiry date, and everyone is slightly different, not enough different to make any clinically relevant difference. But then once you've got all your approvals, you have to go back and then give them all the new testing data, and it takes months to get the testing data and the stability data of the product you're actually using. So you end up going around in circles, and it's an absolute nightmare. Anyway, so the lack of evidence is not through lack of trying. And I think we have to not focus on the paucity of randomized controlled trial data and say, well, we haven't got that, so what have we got? And we've got a darn sight more that we can use, certainly from patient experience. And that's where I've learned most of what I know about medical cannabis is actually from my patients. We did do a survey just before and just after legalization of medical cannabis, and these are the results of the pre-legalization one. We actually didn't have a bad response rate for a mail-out survey, and we were quite surprised by the sheer numbers of patients who were actually taking cannabis. Half had used at some point, but of the previous cannabis users, half of those were still taking it, half of them had stopped, and most of the ones that had stopped, it was old recreational use. But of those that were taking it currently, if that's 800 that responded are representative of the actual whole patient population, it's a quarter of cancer patients who are actually using a cannabis product at some point, and the vast majority of them are taking it either primarily or exclusively for medical purposes. They were also taking it to treat cancer, which we had a lot of concerns about because there really isn't any evidence that it can prolong survival in cancer. Though there's anecdotal reports out there on the internet, you can't rely on them for giving you good information. And there is potential, as I mentioned earlier, for things to actually make things worse, not make it better. So we did repeat the survey again shortly after recreational legalization, and there was a little bit more use and a little bit more disclosure of recreational use, but basically the majority of patients were still using it for medical purposes. They were just having more difficulties getting product, because at the time of legalization, they didn't have enough of the supply lines available yet. So a lot of the recreational walk-in dispensaries that were illegal closed down. And unfortunately, they were actually supplying the majority of the medical cannabis to cancer patients. We did ask patients about side effects. This is not the big survey. This is a separate survey just of patients who had reported using medical cannabis. And it's not that it has no side effects. They just felt that the side effects were quite manageable and substantially less than the side effects that they had from other products like gabapentin or tricyclic drugs like nortriptyline, or opioids like morphine or codeine. We have seen a number of patients get confused if it's excessively dosed, and this is almost exclusively in the population of patients that are trying to cure their cancer by taking high doses of THC. So we would strongly recommend that people don't do that. Just as we see sometimes excessive dosing of THC causing psychosis, this is something that we're actually quite careful about, even in normal or low doses. If someone has a past history of psychosis, like if they are diagnosed schizophrenic or they've just recovered from an episode of confusion during a hospitalization or something like that, or maybe they have early dementia, even severe dementia, and have a kind of a fragile brain, we have to be very careful about giving them THC. So if we were going to use it, we'd start with a very low dose, and we'd make sure that there was at least as much CBD on board to try to reduce the risk of psychosis. The other one, which is not an absolute contraindication, but is certainly one that we would be concerned about, is somebody who had unstable angina or heart failure that was quite severe, because cannabinoids, by whatever route you take, can cause a slight drop in blood pressure. And it's not enough normally to make a difference to perfectly healthy people. But if the blood pressure is the only thing that's kind of keeping the brain perfused or keeping the heart perfused, then there is potential for reducing blood flow and getting problems with that. So we just have to be very careful. The other group of people that we are concerned about use too much of is in youth with high doses of THC, which is almost exclusively seen in the recreational context. But it has been shown that there can be long-term problems with cannabis use in youth, with amotivational syndrome and people becoming actually more paradoxically anxious if they take too much cannabis, whereas low doses actually can relieve anxiety. And then lastly, there's a problem with a cyclical vomiting syndrome, which is very characteristic, usually again only in high dose recreational users, but it's relieved by hot showers. So it's kind of unusual and easy to identify when it occurs. And the only treatment is just gradual withdrawal from cannabinoids so that it settles down. There's really only one drug where we would say there's an absolute contraindication to co-administration, and that's clozapine, which is an antipsychotic. And again, we wouldn't normally be giving people who are on antipsychotics cannabinoids. So that's not usually a clinically relevant problem. There can be sometimes minor reactions with things like warfarin, but nothing that would warrant anything other than just keeping a close eye on it and maybe adjusting the warfarin dose if necessary. The one thing that we do see in cancer patients that we are very uncomfortable with is people taking high doses of THC or CBD when they are on immune therapies, because particularly the CBD can actually function as an anti-inflammatory, which may have an anti-immune effect, kind of like a low-dose steroid almost. And that may diminish the effectiveness of the immune therapy, because we actually want the immune therapy to cause inflammation. So that's one group, and there are a lot of people now taking a variety of immune therapies. It is actually becoming more common, and sometimes it's not entirely clear to the patients what the mechanism of action of their particular systemic therapy is. They're not all chemo, and knowing whether you're on immune therapy or not is sometimes not always entirely clear. Just nearly finished here, 2 more slides here. This one is just to show you what a website would look like if you went on to try to buy a one-to-one oil. This is what I would recommend. It doesn't matter which licensed producer you get it from, but this would be the sort of thing you'd be looking for. You'd want it to be reasonably concentrated. If you could get it more concentrated than this, that would be great. You have to think, yes, the concentration goes up means the price goes up, but you actually use substantially less of it. And if you're taking a small amount and you put it under your tongue, you can actually get a lot more absorbed from the lining of your mouth. Whereas if you swallow it, it has to go through your bowel and then through your liver. So it takes longer to work and you actually get less kind of effectiveness. Because you're avoiding the metabolism in the liver, you can actually get more milligrams of what you ingest going into your body by doing it sublingually than by swallowing it. So the highly concentrated forms are probably cheaper in the long run because you get more bang for your buck out of your prescription. So that's my last slide here, and I'll leave it up there if there's any. I don't know if there's any time for any questions, but I do want people to not be frightened of talking about medical cannabis. There's absolutely no reason why anybody should feel stigmatized for asking for information. We have an excellent website with a handout that people can print out on the BC Cancer website, and it's also it has links to other sources of information. I don't want people to think that it's a panacea, which it's not. There are some situations where you wouldn't want to use it. But certainly, I hope that people have an opportunity to try it at some point if they have no contraindications. Thank you, Larry.
Thank you, Pippa. That talk was just as good as the one I heard last year.
I'm getting better.
Yeah, I didn't hear any buzzing, by the way. That was all on your computer.
It's actually really loud just coming at me, and it's every time we switch slides. It's weird. It's not my computer, it's your system somehow.
Well, hopefully next year we'll be in a non-COVID live together in the same room.
Wouldn't that be nice?
Yeah. Well, thank you very much, Pippa. We'll see if we have time to all the participants. I don't have too many questions, so if you can think of any questions or anything you want to say to any of the speakers, please write them down in the Q&A. So our last but not least speaker today, Sarah Weller. Sarah is a clinical exercise physiologist with a master's in rehabilitation sciences, and she's been the clinical lead for the exercise module at the Prostate Cancer Supportive Care Program. And she also works with the BC Cancer Breast Oncology Unit. So I'm delighted to have Sarah. You'll see she's a terrific speaker, and her topic today is using exercise as a supportive medicine in breast and prostate cancer patients. Thank you, Sarah.
So let's get into it, guys. All right, so today we're going to talk about exercise specific to breast and prostate cancer, and we're going to look at what the evidence tells us in terms of how we use exercise as a supportive medicine. So I'm going to give you a bit of an overview of the benefits and timing of exercise, the safety, and then how to talk to your patients about the specifics of exercise and the recommendations, which I think is a really important part when we look at how do we actually get people to do it. So starting with what is exercise and how is it different from physical activity, which I think is where a lot of people get this wrong. So exercise specifically is any planned, structured, repetitive, and intentional movement that's performed to both improve and maintain one's physical health. So this is going for a 30-minute walk, going to the gym and lifting some weights. It's not generally just being active or getting a lot of steps in your day. Okay, so exercise comes under the umbrella of physical activity. And when we look to the evidence that we have that I'm going to be talking about today, I'm looking at exercise-specific evidence, not just generally getting out and moving. And you'll see that as we kind of go through today. And so when we look at the cancer exercise guidelines, there was an updated cancer exercise guideline released by the American College of Sports Medicine in 2019 that was led by one of our local researchers out of BC, Dr. Kristen Campbell. And what was recommended was that people with cancer should aim for a minimum of 3 30-minute sessions of moderate intensity aerobic exercise per week and 2 to 3 resistance exercise sessions. So this is a little bit different to previous guidance that pushed people towards achieving the physical activity guidelines for healthy adults, okay, which was a little bit more exercise. And what I want to draw your attention to is the moderate intensity. So we're not talking about light intensity. So while light intensity exercise can generally be beneficial, when we look to what the best evidence tells us, it has to be moderate. So that means you get a bit out of breath. Okay, you're working a little bit more intensely than it just being easy. And the other piece that I want to highlight is that strength training is not a nice to have, it is in the recommendations as a recommended guideline for you to be achieving with your exercise. So telling someone to just go and take a walk is not actually good enough anymore, because our evidence suggests that you need to be doing both aerobic and strength training for best health benefits when you're working with people with cancer. And so when we look to how many people actually meet the guidelines, it's kind of disappointing, because we see that only about 13% of prostate cancer survivors and 11% of breast cancer survivors actually meet the recommendations. So we see that most people are not achieving this. And this is where, physicians and healthcare professionals can really help to increase the amount of people that are moving and moving correctly. What else came out with these exercise guidelines was a prevention paper. And this was led by Dr. Alpa Patel and many of her other colleagues. And what they have highlighted from the research is that we now have 7 types of cancer that exercise has been shown to be a strong preventative tool for. And so that does include breast cancer, but it does not include prostate cancer right now with the evidence that we currently have. This same paper looked at survival after diagnosis with cancer. And what we see is that we have strong evidence for breast, prostate, and colon cancer that exercise can help to enhance survival after diagnosis of cancer. For all the other types, we're not really sure yet. We don't have solid enough evidence, but for breast and prostate, we definitely have enough evidence. And then finally, side effect management. So there are 8 things that I've listed here that came out of these guidelines, and these were the Campbell et al. Guidelines from the ACSM roundtable. And so there are 6 things that we now have strong evidence that exercise can help to manage in terms of cancer-related side effects. Things like fatigue, health-related quality of life, physical function, anxiety, depression, and lymphedema. Now, the 2 that we have moderate evidence for, which are the 2 at the bottom, are bone health and sleep. So while we're quite sure that exercise helps, the data right now is still only moderately strong, so it's not as strong as the other areas. Ultimately, what I want you to take from this slide is that exercise can help to both prevent, manage, and in the long term, hopefully increase survival of people who have been diagnosed with cancer. When we look specifically at mortality, this is where I'm going to switch to physical activity, and the only time I'm going to do that today, because that's where our data tends to be in right now. So this slide is looking at the relative risk of people when they were active before diagnosis and people when they were active after diagnosis. And what we're comparing here is the most highly active people versus the lowest activity people. Okay, so we're comparing those 2 quadrants of people. So the highest activity versus the lowest activity. And what we see, you can see I've got a little box there. And this is for pre-diagnosis physical activity specific to mortality. We can see that for breast cancer, we had reductions of 18% of cancer-specific mortality and 21% of all-cause mortality for those who were active before their diagnosis. For prostate cancer, there appears to be no specific cancer reduction and about a 13% risk reduction of all-cause mortality. So that's great if you've got someone who has not been diagnosed with cancer, right? Looking at their activity levels, getting them moving. But for most of us, we're going to be seeing people after their cancer diagnosis. And so what happens then? So when we look at the post-diagnosis physical activity, we see even better results. So if someone's been diagnosed with cancer, their activity from that point is what we're looking at right now. And again, we're comparing the highest active people versus the lowest active people. With breast cancer, we see a 31% risk reduction in cancer-specific mortality and a 41% risk reduction in all-cause mortality. They're pretty big numbers just from increasing physical activity and general movement. For prostate cancer, it gets a few percent better. So we see a 33% risk reduction in cancer-specific mortality and a 45% risk reduction in all-cause mortality. So if you have any concerns or, worries about why you would or wouldn't recommend exercise to someone, this is normally what I go to, because most people want to live and want to live well. And this is a starting point in how you can have a conversation with someone about why they might choose to put themselves through a bit of discomfort and go for a walk and lift some weights and do some exercise after they've been diagnosed with cancer. This slide is really just to highlight all the different side effects and where they come from cancer and cancer treatments. And so what we can see here is that there is a ton of different side effects, right? In lots of different categories. Each treatment produces different types of side effects. I know other speakers have been through these in more detail today, so I'm not going to dive into that. But just know that certain side effects come from certain treatments. So something like fatigue, we expect from every type of treatment, but something like a peripheral neuropathy, we're only really going to expect from chemotherapy. And let's now look at what exercise can do to help mitigate some of these side effects. And again, this is all evidence-based. This isn't me just saying, yay, exercise is good. This is from the research. So from a physiological point of view, we know that we can increase physical function and activities of daily living. We increase muscle strength and size, joint range of motion. We can decrease fatigue. And I'm going to get into that in more detail shortly. We can increase bone density and improve balance and reduce falls risk, which is a huge thing when we start to think about aging population who are diagnosed with cancer. When we look at psychosocial benefits, we can see mental health improvements, decreased depression, decreased anxiety, and increased quality of life. We know that depression and anxiety are very prevalent with people who have been diagnosed with cancer. So these are areas that we want to really focus on. And exercise has now been recommended as a first treatment option for people with depression. So I want you to think about that as well when you're looking at how you prescribe things. And then finally, clinical outcomes. So we know that exercise may improve overall survival. It can reduce the risk of comorbidities. So if we're looking at heart disease, especially with prostate cancer on long-term ADT and breast cancer as well, it can improve surgical recovery and many other things that the research is just starting to dig into some of these clinical outcomes and give us a better understanding of what it can actually do. I want to talk now a little bit about timing of exercise. So many physicians and healthcare professionals that I speak to tell me that they want to wait until the person's finished all their treatment and feeling good before they encourage them to exercise. And hopefully today I can change your mind on that. So we know if we intervene before surgery in prostate cancer, that we can actually improve recovery. And so this graph up here, this is a forest plot, and it shows basically anything to the right shows that it favored the intervention. And this was for pelvic floor training before a prostate cancer surgery, so a prostatectomy. And it looked at returning to full continence, okay? And so what this study found was that the pelvic floor exercise group was 3 times more likely to be continent at 3 months post-op. There have been other studies that also show pre-surgical physical activity levels can help to improve continence 6 weeks post-surgery, and other things like a shortened length of stay in hospital, increased quality of life, improved physical function, and decreased complications. Most of the research in this area is actually in prostate cancer rather than in breast. But if we think about breast, if we're looking at someone who's on neoadjuvant treatment, which we see a lot more of now, we have a really good window now before surgery to potentially enhance shoulder functioning post-surgery. And also if you're having typical kind of treatment pathway and going surgery and then chemotherapy, then we have a window there that we can start to intervene as well, especially if we're looking at trying to build somebody up before their chemo. Let's talk now about chemo. So when someone's receiving chemotherapy, it can be a difficult conversation to also ask them to start to exercise. But the data now is telling us that we need to be getting people to move. There was a study back in 2017 that was led out of Canada by Dr. Kerry Cornier, and it looked at resistance training and aerobic training in people who were receiving chemotherapy. And what they found was that the resistance training group improved their chemo completion rate, which is quite interesting, all right? They also found that improved self-esteem, strength and lean muscle mass, and the aerobic exercise group improved self-esteem as well and maintained fitness and body fat levels. So chemo completion rate, there has been a systematic review done in more recent times, actually from the local group here from Kristen Campbell's lab. And what they found is right now the evidence is a bit mixed because the studies are of varying quality. We seem to think that there's a very high likelihood that resistance training and aerobic exercise could improve this, but we don't have the evidence to support that claim right now. If we move on to the next trial, this was done actually, it led out of Vancouver. The BC Cancer breast oncologists were referring people to a nutrition and exercise program that included aerobic and resistance exercise. And what this program found was that overall activity improved, that health-related quality of life increased significantly, and it was maintained at 1 year post when they did the follow-up. There was a really high patient satisfaction and feasibility was really strong. So the oncologists were really great at referring patients into this program. The patients loved it and the program was effective. And then more recently, out of Sweden, there's been this fantastic trial called the OptiTrain trial. There's a bunch of publications on this now. And what they did was they gave everyone HIIT training, so high intensity interval training. And then you either got resistance training or aerobic training, as well as the HIIT training. And they found some great things. They found that the resistance training plus HIIT prevented increases in fatigue. People were receiving this training and this intervention during their entire chemotherapy protocol. They also found that it improved muscular strength and reduced pain sensitivity. So we often see an increase of pain sensitivity during chemotherapy. They found that both the aerobic and the resistance groups were well tolerated. They were able to prevent fitness declines, and they maintained body mass. And all of these results were maintained at the 2-year follow-up point. It's a really strong study that really shows that intensity matters, and that if we're putting people through harder and higher intensities, that we can actually improve some outcomes. So what about ADT? So when we look at androgen deprivation therapies in men with prostate cancer, we know that we see an increase in body fat, a decrease in muscle mass, and a decrease in bone density. We see that resistance plus impact training. So this isn't just picking up some 2-pound weights. This is lifting heavy and building someone up to safely do that, and then also building them up to have some impact. So being able to jump and do those kind of exercises, we can actually attenuate the loss of bone mineral density, which can prevent possible osteoporosis, which is a really big concern in this population. We can increase appendicular skeletal mass, and the mass of like arms and muscle mass in arms and legs, which often reduces quite dramatically. And we can increase muscle strength. Aerobic exercise has also been shown to decrease fat mass and improve overall body composition. So that's important when we start to look at things like reducing risk of heart disease. There was a meta-analysis published this year that basically just confirms everything that I just said, more specifically from the results. And they found some really good specific outcomes that favored exercise. When we look to timing, and so we'll go to breast cancer now and look at endocrine therapy. So this is either aromatase inhibitors or tamoxifen. What we see is that patients report side effects, and about 91% of patients report some type of side effect while on this. About a third will discontinue therapy because of those side effects. And about a third report that they're reporting their side effects was dismissed or minimized by their medical team, which is a pretty big deal. If we look at this graph on the bottom here, what we start to see, and this was a study that looked at the FACT-ES, or the FACT Endocrine Symptom Survey, over 12 months. And on the left, we have the usual care, and the 3 columns there are baseline, 6-month, and 12-month. And on the right, we have the exercise. We see that the exercise group started about the same as the usual care group and improved. So they had less endocrine therapy symptoms at the end of the exercise intervention. A meta-analysis that was published this year further supports that and tells us that the studies show we can decrease pain, we can decrease stiffness, and we can increase grip strength through exercise when someone is receiving endocrine therapy. Moving on now to after treatment's end, which is a really important timing. This is a figure from the ACSM guidelines that came out in 2019 from the roundtable. And what I want to just go through here is what we now see. They collated all the evidence. They looked at how does exercise impact a side effect of cancer treatment. And we can see those side effects listed on the left there. What they found is we now get a choice. So if you are seeing someone with cancer-related fatigue, as a minimum dose, we can recommend that they either do 3 30-minute sessions per week at moderate intensity, or 2 sessions per week of resistance exercise, or both of those together, right? The 3 30 minutes and the 2 resistance. The reason this is right now we haven't had studies that do head-to-head analyses, but we've seen these outcomes and really favorable outcomes to reduce fatigue across all these types of interventions. So what I would encourage you to do is, where possible, recommend both, because the evidence shows us that we get a better result when we're doing both in general, just for all our health outcomes. However, if someone is resistant to picking up some weights and doing resistance training, walking may be enough as a starting point. So from a behavior change perspective, walking may be a great place to start, but I would then have a conversation with them about resistance training in the future. Let's move on now to fatigue more specifically, because often the message has been in the past that you should just rest. And I really want to highlight that this is incorrect. If you are sedentary, you increase your fatigue, and the evidence tells us that now. From a meta-analysis in 2017, it stated that clinicians should prescribe exercise and or psychological interventions as a first-line treatment for cancer-related fatigue. We really know, we have this strong evidence now that tells us that exercise is needed to reduce your fatigue, and that resting will be detrimental. So who benefits most? We know that the patients who start with the highest amount of fatigue benefit most. That's what this graph shows. Okay, so if you have someone who has high fatigue and you're thinking, oh, well, we probably shouldn't do this because whatever, stop that thinking, because the evidence now shows us that if you have high fatigue, getting you moving is the best thing that you can do. What about safety? I'm going to leave this for you to read on your own. You have these slides. What I want to say is that by referring someone to a cancer exercise specialist, and whether that's a physiotherapist or a clinical exercise physiologist, basically, these are the numbers that we deal with, right? This is what we're considering when we're seeing your patients from a safety perspective. And it is very, very rare that we would not be able to exercise somebody. We might have to make large modifications and big reductions, but we should be able to always provide some type of prescription. And then the final piece I want to touch on is bone meds. So we see a lot of, especially in breast and prostate cancer, we see a lot of bone metastases, whether they be osteolytic or osteoblastic lesions. I've just recently finished a systematic review in this area with an international team that I'm working with. And what we did was we found 17 studies that included patients who had bone metastases. They were either a mixture of resistance training, resistance anaerobic, or soccer studies. And our key findings were that exercise is safe, but we tended to need some type of supervision, even if that was just one session to then send someone on their own at home. It was feasible to deliver, so really great feasibility results. There have been no serious adverse events that have been related to exercise or related to bone mets. And right now, the efficacy is unclear. So we saw no negative effects of exercise, but it's hard to say that it will have a positive effect. We saw a mixed bag ultimately between the studies that had positive effects and those that had no effect at all. Okay, last thing. How do you discuss exercise in 60 seconds with your patient? So based on the latest guidelines from the ACSM Roundtable, and this was paper 3 out of their 3-paper publication that was led by Dr. Katie Schmitz and her team, they recommend that you assess, advise, and refer, and that you treat exercise like a vital sign. So that means you check in on the status with every appointment. So to assess, you ask the person, in the past 7 days, how much aerobic exercise and resistance exercise have you performed? And then you advise. You tell them about the exercise guidelines for people with cancer, the recommendations of 3 30-minute moderate intensity aerobic sessions per week and 2 strength sessions weekly. And then finally, you refer them to a professional, right? So you outpatient rehab, exercise professional, someone to support them. And that's going to be the best way for you to have that discussion. And then the last thing I just want to show you are the local resources. We have some fantastic resources. We have the Prostate Cancer Supportive Care Program that has clinical exercise physiologists in it that specialize in working with people with prostate cancer. We have the BC Cancer Exercise Support page that myself and some colleagues have created over the last few years to really help give you some detailed guidelines. Your patients can call 811 for free and speak to an exercise physiologist that specializes in cancer, and they can guide them through exercise prescription and monitoring. There are groups like Inspire Health that are also free to access that have exercise physiologists with cancer exercise training that can help your patients. And there are private programs and services that are normally fee for service, but myself and other presenters today do work in these programs, and we are happy to help your patients at any point that we can. I have created a Linktree link that will be on your slides that you're welcome to go to that has all of these resources on there and some other information for you as well. Thank you so much for your time today.
Thank you, Sarah. I'm sure that if we were all in the same room and people's microphones are on, you'd hear some great applause. So I'll applause for everybody, for all of our speakers today. It was a long day, a lot of speakers, a lot of information. Before I go on, I wanted to just once again thank our sponsors. I think it's important to recognize our silver sponsor, Tercera, and our bronze sponsors, AbbVie, Astellas, Sanofi, Boston Scientific, Contino by Life 360, Merck, and AstraZeneca. And as I mentioned at the beginning, there are still significant costs to putting on a meeting like this. And we thank our sponsors to allow us to do this virtually. The Q&A, we did not get a lot of questions. I'm not sure, perhaps people are just shy. But we do have one for David Kuhl. If David, you can turn on your microphone. The question is, do participants develop relationships with the other group members? i.e., do they meet or talk to one another after the 3 sessions and before the 3-month follow-up?
It varied from group to group, but the answer is yes. And one of the groups has continued to meet for 2 years after. and not sure what's going to happen this year in terms of COVID. But many of them maintained relationships after the 3 months and into the future. However, we didn't follow them closely. The one group that has continued invites me to join with them every year, so I continue to meet with them.
Okay, thank you. There's a question for Sarah. Sarah, can you turn on your mic? And in one of your slides, you indicated that the exercise persisted for 2 years follow-up. Is that very common? Do you find in your own experience locally that particularly the older men with prostate cancer, that they are continuing on with the exercise programs after their treatments have been completed and they feel that they've been cured?
Yeah, we do find that. And that was that the outcomes, sorry, just to be clear, that was that the outcomes lasted 2 years. So when they did the 2-year follow-up, the outcomes that had improved was still improved, which is, we don't always see that in studies. Often in the follow-ups, we see that everything goes back to normal. Locally, you know, within our prostate cancer supportive care program, with that group particularly, we have a behavior change exercise clinic. And so from what we've seen so far with those participants is that by helping with their behavior change, not just by, you know, giving them exercise to do, but actually motivating them and encouraging them and overcoming barriers for exercise, we're able to implement long-term behavior change. And we get the buy-in from people around overall health as well. And, you know, it's not like you finish your treatment and then you feel great. Most people feel pretty crappy for a few years as well. And that's a reality. And so it's a lifelong process. And we find that we get good buy-in from most people.
Sarah, another question from Dr. Schenk here. How, if at all, do you incorporate HIIT instead of moderate times 30 minutes?
Right. And that's a great question. So I would encourage people to incorporate it by putting in small doses. So let's say you have a 30-minute, let's say you're going for a 30-minute walk. And what you might do is when you're introducing HIIT to somebody is to get them to do three 1-minute pickups within that. So they go really hard 3 times within that entire 30-minute period, but that really hard part will just last for 30 seconds, a minute, or something shorter. And then they can increase that over time. So that's what I would recommend someone start with. And if they're doing more intense HIIT, so let's say they're doing a minute on, a minute off, that type of protocol, then you can normally do less overall. So you'd warm up, you can do like 10 minutes of HIIT training and then cool down. And we've got evidence that shows that that's just as effective as 30 minutes of moderate.
Okay. Pippa, you're online now.
Yeah.
So the question was, how can we help you get your clinical trial started once and for all?
It's a very nice question, and I wish there were something that my patients could do. I am completely bound by Health Canada, and they are an absolute nightmare. Insert swear word before nightmare. And if you can encourage your member of parliament to get Trudeau to fund Health Canada properly, then that would be great. I think a lot of it is that they have so much they have to do. And with COVID at the moment, it was bad to start with, but it's even worse now because they've got so much extra stuff that they have to be focusing on with COVID. So, I have to be aware that there are priorities, and maybe this is, medical cannabis research is probably something that they figure is low priority. But it really has been a disaster from their perspective. It's just the same with all the legalization. Don't get me started. Every time Health Canada seems to come up with some new legislation or new regulation for medical cannabis, they screw it up and they make it worse. So I don't think they really want people to take it, but you have a right to take it. The Supreme Court has deemed this a human right. They cannot, no physician or other healthcare provider can legitimately block somebody from accessing this. And they can't keep saying, oh, well, we don't have the data, we don't have the research, if they won't let us do the research, So that's entirely what we're restricted by is Health Canada.
Wow.
I've got lots of money and good people, and we're all ready to go.
Okay. David, do you see a role for cannabis and from a point of view of the anxiety and the stresses that newly diagnosed and treated patients are suffering from?
Yes, in terms of prostate cancer, it's also relevant to the work I do with first responders, military, in terms of some of the other identified areas that Dr. Holly talked about as being effective. So it's an important study. It needs to. I'm with you, Pippa. It needs to happen.
So they can't access.
We're very close.
Sorry.
We are very close. It won't be long now. We should be able to start before Christmas.
Can the military access it?
Well, it's the same as it's the top categories that Dr. Holly had in the black, the red, and the green. People accessing, right? And if we could get the studies to demonstrate and prove its true effectiveness, it would be just easier for them, because you don't always know what it is you're getting in the product that you buy, and they don't necessarily understand all the complexity of what's important for which component of your experience.
Yeah.
Yeah. Pippa, one of your green lines mentioned nabilone. Is that being used a lot in place of cannabinoids?
Nabilone is a synthetic molecule that will agonize the cannabinoid receptors, both CB1 and CB2. Yes, it is being used, and it is approved for management of nausea and vomiting in people with cancer, chemotherapy for cancer, and it is definitely being used. And I think it's being used off-label in a number of other situations as well. It's probably being used for anxiety, which I wouldn't actually encourage. I think it's probably not the best cannabinoid product. It'd be better to have something with some CBD on board. So I wouldn't encourage that. But it certainly is being used out there.
Okay. Any other? I don't see any more questions on the chat line. So it's been a long day. I'd like to once again thank all of our presenters. Every one of them was terrific. Great talks. I think we covered a huge amount of territory in the world of survivorship or supportive care for both prostate and breast, as well as other cancers. Congratulate Monita and Jenna for all the hard work that they put into making this a reality. There are a lot of details, chasing speakers. Speakers, you know how you've been chased. And putting together the conference handbook. Again, for the participants, the handbook is on the right side under handouts at the bottom. It's called Conference Agenda and Slides. You can download that. It has most of the slides from all of the speakers. Dr. Moyad just put in his highlight speakers. If you want to learn more about his work, he wrote a tremendous book called The Supplement Handbook. And I think it's a great book. And if your patients are asking about supplements and are very interested in all these complementary approaches, I would highly recommend that they go on Amazon and order the book, The Supplement Handbook by Mark Moyad. Mark didn't ask me to advertise it. I just think it's a great book. Again, thank you to our sponsors. Remember that you will be emailed an evaluation form. I ask you to please fill that out. And you'll also receive your CPD certificate. And the presentations were video recorded, and a link will be sent to you as well. So thank you again. It's 3:20. That's what time we were supposed to have finished. I appreciate, again, everybody's participation, and have a great weekend. Thank you all.
Nice to see you, David.
And you, Pippa, very much so. Thank you. Bye-bye.
Bye.
Bye-bye.